For those who are online, just so you know, we're going to get started here in just a minute. We're just trying to get situated in the room. Good afternoon. We can get started. I'm at-large Councilmember Christina Henderson, Chairperson of the Committee on Health. Today is Thursday, February 9th, 2023. The time is 2:09, and we are live and in person from Council Room 412, but we're also broadcasting via the Zoom internet platform, as well as cable channel 12 and on my YouTube page at CMC Henderson. I'm calling this meeting of the Committee on Health to order for the second of two performance oversight hearings for the Department of Behavioral Health. Yeah, okay. Last week, we held a hearing for public witnesses, and today we will hear from Dr. Barbara Bazaran, Director of the Department of Behavioral Health. As a reminder for folks, the Department of Behavioral Health, often referred to as DBH, provides prevention, intervention, and treatment services and supports for children, youth, and adults with mental and/or substance abuse disorders, including emergency psychiatric care and community-based outpatient and residential services. DBH serves eligible adults, children, and youth and their families through a network of community-based service providers and government services. DBH manages the district's school-based behavioral health program and operates St. Elizabeth Hospital and the district's inpatient psychiatric facility. DBH serves district residents based on the belief that they can recover from mental health and substance abuse disorders and live happy and healthy, successful lives. The COVID-19 pandemic exacerbated the existing crises that many residents were facing, and at the same time made it more difficult for DBH and their partners to provide critical services. Last week, we heard from nearly 70 public witnesses, including students, community-based providers and contractors, interested community members, and advocates. They spoke on a range of issues, including the opioid addiction crisis, the urgent need for more clinicians and behavioral health staff, youth stress and trauma, and the need for increased accountability to DBH for programs and services. Dr. Bazaran, witnesses spoke to your intentional engagement and willingness to collaborate, as well as your deep commitment to the health, wellness, and safety of district residents. I, at this point, would like to welcome my colleagues on the council in attendance to make any opening statements. And then after these statements, Dr. Bazaran, you'll have an opportunity to make your statement, and then we'll begin for discussion. So I'm not entirely sure who arrived first. I'll let you two decide. Okay, it was Councilmember Lewis George. All right, go ahead, Councilmember Lewis George.
Good afternoon. Thank you, Chairwoman Henderson, for allowing me to join this afternoon's hearing to discuss some of my concerns about the state of behavioral concerns in the city right now. And good afternoon to Dr. Bazaran and her entire team. As you just noted, many community members have spoken to the intentionality of Dr. Bazaran's work and her care for this community. So I want to continue to thank her for her service to our city in that regard. From where I'm sitting, when it comes to behavioral health and emotional well-being, our city is battling 4 crisis areas. One, violence. As the violence has comes in many forms, and as we know, it is the default when someone is not able to regulate their own social emotional behaviors. Second is the mental health of DC youth and the impact of violence and pandemic-related isolation on child development, which also ties into the increases we have seen in youth suicides. Third is obviously drug abuse and overdoses and our current state of our opioid crisis. And fourth, staffing shortages in every aspect of behavioral health and direct care work. I want to thank the witnesses testifying last week on these various topics to help shine light on where and how our city can be doing better to meet various mental and behavioral health needs. At today's hearing, I'm excited to dig into the following topics with Director Bazaran. One, the expansion of DBH's community response team, also known as CRTs, violence-related trauma counseling in schools and communities, and general promotion of DBH services to help more residents access care. The results of DBH's findings on cost estimates for expansion of school-based behavioral health programming, staffing levels and services of behavioral health professionals in our education settings from birth through graduation, i.e. our Healthy Futures and our school-based mental health clinician programs, and the Long Live BC campaign and how the city is doing on crisis response strategies to drug overdoses, how we hire all the staff we need to fill these critical behavioral health roles. I know I brought this up in hearings last year. If we are giving police $20,000 in housing to help join the force, what is the equivalent incentive for our behavioral health force? Is it a 20,000 signing bonus, housing help, student loan forgiveness, whatever it is? I want to be able to figure that out with this committee and this committee chair and Director Basram. And so I look forward to digging into all these topics and more today. And I thank you again, Councilmember Henderson, and I look forward to working together to strengthen behavioral health care under your new leadership of this committee. Thank you.
Thank you, Councilmember Lewis George. Councilmember Parker.
Thank you, Chair Henderson. I tend to like to keep these opening statements short so we could jump right in. I do not see Dr. Basran on my screen, but if you are here and you can hear me, I'm looking forward, Dr. Basran, to hearing from you and to asking questions. In last week's oversight hearing, which was a bit of a marathon and stretched on and late into the evening, we heard repeatedly both about the praise and appreciation many have for what your agency is doing, but also concerns around needed improvements around substance abuse and our work there, as well as behavioral health and mental health supports in our schools primarily. There are a number of vacancies that bring concern, or I have concern about, and I want to delve deeper there. But I'm hoping today's conversation sheds light on where we can work together to address these needs as the district continues to come out of a pandemic. So with that, I'm going to turn it back over to you, Chair, but looking forward to a spirited conversation.
Thank you, Councilmember Parker. Before we turn to you, Dr. Basran, I want to check in with our folks. So it seems as though you and I can be seen on cable TV. We can also be seen on the council website, but we cannot be seen in this Zoom. So that last part is not what has been happening. So we're just trying to figure that part out. And I want to make sure that you can be seen when you're giving your testimonies. If you just give us just a minute.
Also, we can't see you or Dr. Basran, but I assume you're all smiling.
Yes, ma'am, I'm here and smiling.
Okay, we are back ish in a very interesting setup. Here. But we're on team Make It Work. Okay, so now everybody should be able to see us. We should be seen on cable, online, and all the various things. And of course, Councilmember Parker, we'd always welcome for you to come upstairs and join us in person.
I may take you up on that.
Okay, all that being said, Dr. Bazaran, before you begin with your testimony, we have a new rule for the council. Everyone has to be sworn in, all of the government witnesses. So if you could raise your right hand, do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia and this committee is the truth, the whole truth, and nothing but the truth?
I do.
Okay, great. You can go ahead and begin. And if you don't mind introducing the individuals that you have at the table with you as well, that'd be great.
I'm sorry.
Introducing the folks who are with you.
I will certainly.
Thank you.
Okay. Good afternoon, Chair Henderson, committee members, and council staff. I'm Dr. Barbara Bazaran, Director of the Department of Behavioral Health, and I want to thank you for the opportunity to discuss DBH's performance in fiscal year 20 and 22, and to date in fiscal year 2023. I have members of my teams here with me. To my far right is Barbara Paulson, Director of Child and Adolescent Services. To my immediate right is Dr. Richard Bebout, who is our Chief of Crisis Services. And to my left is Dr. Jean Moise, who is the Director of Adult Services. Mr. Mark Chastang, who is the CEO of St. Elizabeth's Hospital, and as well as our Chief Operating Officer, Mr. Michael Neff, and our Chief of Staff, Ms. Phyllis Jones, are also with us here today. Under the leadership of Mayor Bowser, DBH helps support healthier and stronger communities by working to prevent the onset of mental health and substance use disorders and providing a range of community-based treatment and recovery services and supports. We also provide crisis services, operate adult and child urgent care clinics, and manage St. Elizabeth's Hospital for a 24-hour psychiatric inpatient stay. Through Mayor Bowser's continued investment supported by the council, DBH is transforming publicly funded behavioral health care into a whole person, culturally competent, integrated behavioral health care system that ensures services for those who need them and embraces our role as the state authority responsible for improving population behavioral health outcomes and advancing health equity. Under the strategic direction of Deputy Mayor Wayne Turnage, DBH partners with agencies within the Health and Human Services cluster and throughout government to integrate information and access to behavioral health care and to normalize behavioral health treatment as essential to daily living as housing or a job. DBH is addressing the same challenges facing our country today, strengthening the behavioral health care system, including addressing workforce shortages, expanding access to care, improving health equity, enhancing child and family well-being, the opioid epidemic, and addressing the mental and emotional impact of the pandemic. We are making meaningful progress on these priorities. Our work has never been more important, and I am honored to lead DBH at this critical moment. Studies have shown that the COVID-19 pandemic had a profound and continuing impact on the mental health of all of us and has placed an enormous strain on individuals, families, and communities. The impact was even more pronounced on people already facing mental illness and substance use disorders. Gun violence and safety concerns place additional stress for too many of our community members. I want to take a moment to address the misconception about violence and mental illness. Too often, incidents of gun violence and incidents of mass violence are linked in the media and public discourse to mental illness. When senseless tragedies occur, people look for answers, and too often the answer is mental illness. The fact is that most violent acts are not due to mental illness, and most people with mental illness are not violent. Studies show that 3 to 5% of violent acts can be attributed to people with serious mental illness, while people with mental illness are 10 times more likely than the general population to be victims of violence. Further, this misconception ignores the reality that millions of Americans manage their mental illness with effective treatment, coping strategies, and self-care, and are living up to their optimal potential. Let me tell you about a few of them right here in our community. Jerome is a valued employee with the DC Public Library System as a certified peer specialist, one of nearly 200 peers trained by DBH. George, and that's not his real name, after receiving treatment at St. Elizabeth's Hospital for 38 years, has been living independently in his own apartment with supports for 3 years. And Imani has been in recovery from cocaine addiction for 20 years after entering residential treatment as a young pregnant mother. There are more than 41,000 residents of all ages who receive treatment and supports to sustain recovery through DBH. Today, I will be reporting on our progress implementing strategic initiatives, but I'd first like to give a brief overview of the public behavioral healthcare system and its utilization and expenditure data. DBH contracts with 50 certified providers to deliver mental health services and 24 certified providers to deliver treatment and recovery supports for substance use disorders. 13 of these providers also are certified to provide mental health treatment. The trend of increased utilization of mental health services and increased expenditures continued in FY22. Based on claims data, 41,560 people received mental health treatment through DBH, 8% more than in FY21, and a 24% increase since FY20. There was a 22% increase in expenditures from FY21 to FY22. Nearly half of these expenditures were for telehealth. There was a 6% increase in the number of people who received substance use disorder services. A total of 5,265 residents participated in treatment, primarily in person. Significantly, 61% of people received treatment for substance use disorder services also received mental health treatment. Though there was an increase in utilization, total expenditures for substance use services decreased by 8%. In total, $319.7 million in Medicaid and local fund supported treatment in the public behavioral health care system in FY22. This amount is based solely on claims and does not include services supported directly with contracts or grants funded with local and federal dollars. As you are aware, the last rate increase for behavioral health services was in 2016. DHCF contracted with an independent company to review the rates. We will consider the recommendations together, and any rate adjustment will be included in the Mayor Bowser's proposed FY24 budget. In our response to the committee's pre-hearing questions, we provided a comprehensive report on our performance. And I will focus my testimony today on our progress on 4 key strategic initiatives: behavioral health transformation and integration with managed care, enhancement and consolidation of crisis services, expansion of early childhood and school-based services, and implementation of the district's plan to combat the opioid epidemic. I will begin with the behavioral health care transformation and integration with managed care. DBH and DHCF are now in the provider planning and readiness phase of our multi-year plan to fully integrate behavioral health care services into the district's Medicaid managed care program. We first surveyed providers so that they could identify their challenges and are responding with multiple technical assistance opportunities and provider forums. One example of the support provided was the development of a business and administrative operations best practice manual. We are working very closely with providers to identify and implement changes in how they will conduct business in a managed care environment. The integration of services will standardize certain operational procedures and reduce administrative burden. For example, service authorization that is now done by DBH will become the responsibility of the managed care organization. This will consolidate that function within a single entity. We are exploring how the billing and claims function can be streamlined. Technical assistance will be provided on revenue cycle management for all providers to support their operational integration with managed care. The foundation for whole person care is timely access to both physical and behavioral health data. We will require that a provider have a certified electronic health record to capture and enable the transfer of health information. DBH worked with DHCF to obtain grant funding to support providers to implement, enhance, or optimize their electronic health record. 64 of the 73 DBH providers, or 88%, are participating in the electronic health records program. Incentive payments totaling $1.8 million are available along with a supportive team of systems experts. In addition, DBH is in the second year of implementing its integrated technology engine. The ITE will support integrated care and access to a wide range of data that will support population health. DBH will complete phase 2 of the ITE by October 1 of 2023. Along with changing business processes, we are transforming how services will be delivered and measured to be able to take advantage of the promise of integrated care to improve health outcomes. We are working with providers to improve overall performance and targeting improvements in services that support our most vulnerable residents. Our North Star is that people with behavioral health disorders will live healthier, longer lives. We are working with mental health providers who manage assertive community treatment, ACT teams, who support consumers with the most complex illness with additional training on clinical standards to get the best outcomes. We also made available grants up to $58,000 per ACT team to support staff recruitment, retention, and training. As we reshape and better coordinate the components of our crisis services, we are working to ensure that ACT teams are a part of the crisis response and that crisis management is a part of treatment planning. DBH is targeting support to providers of substance use disorder services with extensive training and technical assistance on person-centered care and treatment planning using nationally recognized medical necessity criteria. DBH works with DHCF to provide additional funding to help offset revenue losses during the pandemic. We are on course to open a new sobering and stabilization center this spring to support individuals under the influence of alcohol or drugs who require stabilization services and supports, but do not need to be transported to a hospital emergency department. We believe the new sobering center will be a low barrier stepping stone to ongoing treatment and sustained recovery. Through the Accountability Administration, we are supporting provider performance with regular oversight of compliance with licensing and certification regulations, corrective action plans, and claims audit. We detailed the compliance activity in our response to a pre-hearing question. I want to highlight one new requirement for certified providers to obtain a national provider identification number for themselves and all staff, and to include those numbers on each claim. This requirement will allow DBH and our partners at DHCF to better track, detect, and deter false claiming. It will take effect April 3rd of 2023. In FY22, we return to publicly reporting on the performance of behavioral health, the behavioral healthcare system overall, and for each provider. Our goal is for providers, consumers, clients, advocates, policymakers, and others to have a clear picture of the public behavioral health system and to use the report to foster improvements. Our first provider performance report covered fiscal year 2020 and makes data available on 7 key performance indicators. DBH providers met or nearly met performance targets on 4 of the 7 KPIs. A preliminary review of fiscal year 2021 performance measured against 10 KPIs shows that providers met or nearly met targets for 8 or 80% of the KPIs, a substantial increase. On a systems level, provider performance improved on 5 common KPIs, including timely access to mental health care and continued care for people with substance use disorders after completing residential treatment. When we fully integrate services into managed care, DBH will continue to certify providers. Effective October 1 of 2023, we are requiring national accreditation for one of 3 accrediting bodies to be eligible for certification. National accreditation demonstrates programs and services are conducted in a manner that is consistent with established, field-tested national quality of care standards. Currently, 23% or 17 providers have national accreditation and another 28 have applications pending. DBH is providing grants and providing technical assistance to support providers to achieve national accreditation. I will now report on our work to strengthen crisis services. Mayor Bowser launched the new, easy-to-remember 3-digit 988 Suicide and Crisis Lifeline last July. Access Helpline has been certified as the district suicide prevention call center for many years. Calls to the 988 Lifeline increased more than 50%, which indicates that it is easier for people to get the help they need when they need it. DBH has achieved a sustained answer rate at or above 90%, which exceeds the 80% national standard. Consistent with national data, most callers receive the support they need from the crisis counselor, and no additional intervention is required in that moment. We will continue to work closely with our partners, MPD, Fire and Emergency Medical Service, and the Office of Unified Communications to transfer certain behavioral health related calls from 911 to DBH as directed by Mayor Bowser. In FY22, we expanded the 911 diversion pilot from 12 hours to 24 hours a day, 7 days a week, and are preparing to co-locate staff at OUC. To support the increased calls, the mayor invested substantial resources to nearly double the number of trained crisis counselors at the Access Helpline and the community response team. We are aggressively recruiting to fill these new positions. Our CRT is comprised of teams of licensed clinicians, peers, and behavioral health specialists who provide a clinical response to crisis calls and have regular and ongoing presence in the community. In FY22, the CRT received 5,828 calls, about a 4% increase. The CRT resolved 46% of the calls through telephone support and was dispatched on site for the remaining 54% of calls. When the CRT is dispatched, it works to resolve the crisis on site. In FY22, the CRT clinicians determined that additional care was needed to prevent harm to an individual in crisis or to others in 15% of the on-site incidents. CRT relies on MPD to transport those individuals for involuntary treatment to our emergency psychiatric facilities or community hospital. The CRT is careful to provide the clinical support to minimize the impact of what could be a traumatizing event. In a small number of incidents, once on site, the CRT determines that MPD support is required because of safety concerns. In FY22, the CRT requested MPD support in just 7% of the calls that did not result in transportation to involuntary emergency care. In FY23 to date, the CRT requested MPD to support 5% of such calls. In addition to supporting individuals in crisis, the CRT provides trauma support and psychological first aid to communities impacted by traumatic and tragic events. The CRT also responds to calls to engage individuals who appear to need behavioral health care and is dispatched to areas with spikes in opioid overdoses to promote harm reduction options. An unanticipated demand for CRT has come from district government agencies experiencing homicides or other traumatic losses among staff. We are expanding our staff to provide counseling support for survivors of natural and human-made disasters to implement the pilot program in our FY23 budget envisioned by Councilmember Allen. DBH has partnered with MPD since 2009 to train patrol officers called crisis intervention officers to recognize the signs of mental health and substance use disorder and to use the most effective de-escalation techniques. The CRT and CIO often respond to the same crisis situations when safety is a concern. At the direction of Mayor Bowser, DBH and MPD are examining setting up a co-response model where CRT and police partner to respond together. In FY22, the mayor expanded training by mandating that all police officers and recruits receive mental health first aid training, a course that teaches participants how to identify, understand, and respond to signs of mental illness and substance use disorders, and how to refer individuals to service. One of the more concerning trends exacerbated by the pandemic is the impact on youth mental health, including children who had never previously displayed symptoms of a behavioral health disorder. DBH has provided trainers, has trained providers to offer evidence-based practices with a focus on trauma support proven to impact functioning at home, in school, and in the community. In FY22, DBH added training in 3 new evidence-based practices for early childhood and youth substance use disorder treatment for infants and youth to ages 18 to support families. Emergency mobile crisis services are available to support youth and families in the home to help children experiencing a behavioral health crisis avoid hospitalization and support healthy family living. We continue to expand Healthy Futures and Child Development Centers. In FY22, services were provided in 85 child development centers and 18 home providers. DBH began treatment services and 8 child development centers in communities most impacted by the pandemic. DBH continues to make progress in placing a school clinician in every public school while facing significant workforce challenges. Currently, 163 or 64% of public schools have a clinician on site, either from partner community-based organizations or DBH, or both in some schools. In schools where CBOs have been unable to hire a clinician, supervisors are providing limited prevention and early intervention services and helping to complete the school strengthening work plan. DBH is implementing short and long-term solutions to address the shortage of licensed mental health professionals. DBH provided funds to support increased salaries for hiring and retention bonuses. In addition, DBH is providing $1,000 for each clinician to pay for licensing fees. A new DBH intern coordinator is working to increase the recruitment of interns from local colleges and universities. Given our experience over the past 4 years and the difficulty hiring and retaining nearly 300 licensed social workers, we are re-examining the expansion model. While I am not budging on the requirement that treatment must be provided by a licensed clinician, we are considering whether prevention and early intervention activities can be performed by individuals with a bachelor's degree in a related field. DBH is leading this conversation with the broad-based coordinating council that is guiding the expansion, our education partners, and this committee, and any changes will be made before the next school year. This analysis will be supported by the fiscal and program analysis of the school-based program that was required by council, which is expected to be completed by mid-March. Engaging youth in substance use treatment remains a challenge. It is encouraging that the 219 Youth Risk Behavior Survey conducted by OSSI shows reported alcohol and illegal drug use declined. However, 13.1% of high school students reported using illegal drugs in the past 30 days, and 20.2% reported at least 1 drink of alcohol. Students who self-identified in the survey as LGB remain overrepresented in the number of students who reported substance use. DBH has focused attention to increase the number of youth enrolling in treatment and recovery support services. DBH supported outreach and engagement activities with a federal grant to youth treatment providers. We support 4 prevention centers that build youth leadership to promote drug-free living through education, social media, and community activities in all 8 wards. In FY22, the prevention centers held 87 educational panels and 32 youth-focused events. They also conducted 47 naloxone trainings and produced a creative and informative video on social media that warns about the dangers of fentanyl and promotes naloxone. I now want to turn to the implementation of the district's plan to combat the opioid epidemic. Since Live Long DC, the district's comprehensive plan to reduce opioid use, misuse, and related deaths was released 4 years ago, DBH and its partners have focused resources, services, and outreach on best practices in prevention, treatment, harm reduction, and recovery supports. Based on the most recent Chief Medical Examiner's report from January to October of 2022, the average number of deaths continued the reversal of the 2-year upward trend in 2020. While it is encouraging that the rate of death has slowed, we are committed to reducing the number of deaths by doubling down on harm reduction strategies, increasing access to treatment, and expanding recovery supports. Opioid overdose deaths is preventable. Lifelong naloxone is widely available at no cost, with no ID or prescription required. The district is the national leader in per capita naloxone distribution. In FY22, DBH partnered with 130 community-based organizations and other DC government agencies to distribute naloxone kits. DC residents also can text for personal delivery or to get it by mail. More than 65,000 naloxone kits were distributed, an increase of 14% over 2021, when 58,810 kits were distributed and double the number distributed in 2020. With the law change by council, district government workers and contractors have joined community-based providers to distribute fentanyl test strips to warn unsuspected users of the presence of that deadly synthetic found in 96% of opioid overdose deaths in 2022. These harm reduction strategies have one goal: keeping people alive with the possibility of treatment and recovery. Through the district's combined effort, we are making it easier to get treatment through multiple entry points that include certified community-based providers, medication-assisted treatment centers, and emergency departments of 6 community hospitals, 8 community health centers, and a roving DBH mobile van. Substance use disorder treatment units for women and men are in use in the DC jail. The 6% increase in the number of people receiving substance use disorder services includes a small increase in people receiving medication-assisted treatment. To ensure that transportation is not a barrier, district residents can get free round-trip rides to opioid treatment and recovery supports. I know combating the opioid epidemic is top of mind for the committee, and in our discussion, we will provide more detail about our work. The impact of COVID-19 has sped up efforts to improve access to mental health and substance use disorder treatment options. Long-standing health disparities across populations were exacerbated by the COVID-19 pandemic, with people of color disproportionately affected by severe illness, death, and associated economic loss. DBH has adopted strategies to improve health access in vulnerable communities. During FY22, DBH implemented an intensive care coordination initiative to focus support on individuals with serious mental illness who go in and out of care, often have chronic medical conditions, and are unhoused. The ICC team reviewed the records of 762 consumers previously disenrolled by providers, many because they couldn't be located, to attempt to reconnect them to care. The ICC connected with 460 of them, and 60%, 276 people, were reconnected with a provider within 30 days of engagement. DBH contracts with a certified provider, MBI, to support individuals living in the DHS PEP-V sites set up for individuals most at risk for hospitalization or death due to underlying chronic medical conditions. DHS reports that on February 2nd, the census was 478 and 412, or 87% of the residents were enrolled with the DBH provider. MBI works closely with the providers to coordinate care and to track their progress on a permanent housing plan. DBH has a robust public engagement program to share information about available services and promote access to care. In FY22, with DC reopened, DBH provided and participated in 844 public events, up from 721 events in FY20. Our public engagement has resulted in more visits to our website and increased social media presence. We partner with faith leaders, advisory neighborhood commissioners, behavioral health advocates, civic leaders, and a range of community organizations to spread the word that effective treatment is available and to combat stigma and stereotypes that often prevent people from seeking help. We work to ensure that language is not a barrier to care. We actively recruit bilingual staff, making available language and sign language interpretation, and translate outreach materials in 5 different languages. DBH certified providers are also required to provide interpretation services. I want to conclude my testimony by expressing my appreciation for each member of Team DBH, our providers, and our government partners. I want to acknowledge certified peer specialists, leaders of consumer and recovery groups, and peer-led centers who model our conviction that treatment works and prevention is possible for everyone. With Mayor Bowser's direction and investments and the support of council, we have an opportunity to transform behavioral health in Washington, D.C., and we are ready to meet this challenge. Thank you, Chairperson Henderson, for your leadership and commitment to the health and well-being of all district residents. I look forward to our continued work together, and I'm ready with my team to answer any questions.
Great. Thank you so much, Dr. Bazran. We'll do 15-minute rounds. So that hopefully will allow for my colleagues to have a fulsome discussion. Oh, okay. I was like, that will allow for my colleagues to have a more fulsome conversation about a particular topic that they raise. Okay. I want to start to just ask some questions in terms of the org chart that you all submitted to the committee, which I find to be incredibly helpful. So thank you so much for making that available. It's also nice to see your team available here so I can put faces with the boxes. It seems from your chart that you have 2 high-level positions that seem to be vacant: the Director of Policy Planning Evaluation and the Senior Deputy Director. Have those positions been filled, or do you have candidates in the pipeline?
They have not been filled, but certainly we are recruiting for them. The one thing we're looking at in terms of the policy planning and evaluation lead as we move to our transformed state, what does that need to really look like? So we are thinking that through.
Okay, so that position hasn't been posted
It has
yet?
not been, yeah.
Okay,
posted.
and what about the Senior Deputy Director?
It has not been posted yet, no.
Okay, all right. We'll check in on those during budget time. Maybe perhaps by then
Absolutely.
you'll have those.
Yes.
Okay. In your responses to the committee, you shared the numerous ways that DBH measures the quality of services provided by your community-based providers, including claims audits, medical reviews, consumer interviews, et cetera. But despite these efforts, there are continued reports from residents about poor experiences that they have. Obviously, you can't account for all of those pieces. But what do you feel like are the top areas of improvement within the DBH network that's necessary?
Well, I think that here again, we're working very hard, as I said in my testimony, to make sure that first of all, that providers are providing the services with fidelity, because quality of care is extremely important. We here are very lucky that we have embraced many evidence-based practices. that really have proven to make a difference in the lives of people with mental health and substance use disorder. And so one of the things that I think is very important is ensuring that those services are provided with fidelity. We do know, for example, that one of the areas in which we're really focusing on is assertive community treatment, for example, where here, because of some of the workforce issues, the staffing has not been consistent with the fidelity model, and we are working with the providers to address that issue, and also bringing in the developers and experts in ACT to work with our providers around the delivery of care. The other thing that we're looking at are things like ensuring that medical necessity criteria is being met by our substance use disorder providers. We use the ASAM criteria, which is a national standard of care, and we want to make sure that that too is done with fidelity. The other thing to me that's even more important is what we get out of our consumer surveys, how people are experiencing the services that they get. We look at those very carefully, and our provider relations group works closely with the providers to address any issues that we have. I can tell you that our Office of Accountability, along with provider relations, along with our program staff, look very carefully at that person experience and at the quality of care standards. And with that, we hope that we will be able to make a difference.
Sorry. So with that, if someone is having a complaint, they should feel free to reach out to your office,
Absolutely.
regardless of where their insurance is and those kinds of things.
Absolutely. We do have an ombudsman,
Okay.
and they certainly can call the ombudsman's office. We also have a line that they can use if they have a complaint, and we do
like a
follow
tip
up.
hotline,
A hotline,
okay.
yes. And we do follow up in both of those instances, follow through and investigate whatever that instance happens to be.
Okay. And how many, or how do you all dispatch the consumer surveys?
How do we dispatch the consumer surveys?
Yeah. Is it a sample size of, I mean, I think you said in your testimony of
Sample size.
41,000 people receiving services. So I can't imagine that you're surveying all those people. So I'm just curious how that works.
Yeah.
Thank you, Dr. Bazran. It's actually a sampling of our outpatient population
Okay.
Mhm.
and across the spectrum of care, all the providers within our network.
Okay. Thank you. So you mentioned in your testimony in terms of wanting to provide additional language access and or to make sure that
I'm
we
sorry.
language access.
Uh-huh. Mhm. Okay.
And so I'm curious how or what strategies you all are using to increase the number of providers who communicate in languages other than English.
Well, first of all, as we know, there's a huge provider shortage all across the country. However, what we do is we attempt to tap into those groups that of color and try to identify individuals from them. We also have some of our agencies like Latin American Youth that really specialize in providing services, particularly to the Latinx community, and they are very much ensconced within the Latin community and are able to attract people to their teams. And so, you know, we advertise. We engage with communities, diverse communities, and make our opportunities known and available to them, and hope that they will apply for the many jobs that we have available.
Yes. We'll talk a little bit about that. Obviously, we know that like part of getting more providers to come in is around the payment and rate system. So I want to just ask for an update on the study. When do you anticipate the completion of the provider rate study?
Well, the provider rate study, we are anticipating that within the next month we will have we should have completion of the study. We're working in partnership with the Department of Healthcare Finance. And I have to tell you, it's a very complicated process because what we have done is we've looked not only at the existing expenditures from our own provider network, but we've also looked at the way those services, the cost of those services in comparable other areas, because we want to get a true sense of how much it really costs to operate the service.
When you say other areas, are you talking about other
Urban areas.
other jurisdictions?
Other
Okay.
jurisdictions.
As part of the study, do they ask providers, what do you need?
Yes, when
I'm saying it in a very colloquial manner, but I'm saying, like, if we're just looking at expenditures, we're not necessarily getting the full picture of what it might actually cost to deliver the care.
Well, actually, yes, we looked at what will it actually cost to provide this service to Fidelity,
Okay.
to the particular model. And so that's really the standard. And that's part of the data that's being used. And that's why I said it's more than just what is the immediate cost now, but what does it really cost if we do this to Fidelity?
Okay. And how do you anticipate that this might impact the FY24 budgets?
At this point, I don't know. I think
Okay.
it's too early to tell because I haven't seen the data.
Okay. All right. Well, we'll come back to that when we see the budget. We'll come back to
Yes.
that. So I have to say, when the president made the announcement that we were getting ready to wind down the public health emergency, it gave me a little heartburn in that the timing seems to all coincide where we're going to be doing redeterminations of Medicaid at the same time that we're doing transition of DBH to, or of behavioral health to MCOs, or doing sort of happening at the same time. And so I think that the best way for us to get ahead of that is to make sure that the transition planning is happening and that folks are working in concert. And so is there a liaison right now between your agency and healthcare finance in terms of the smooth transition to MCOs?
Well, I have to tell you, we are literally linked at the hip.
Okay, that's good to hear.
No, I'm very serious. And Melissa Bird, the Medicaid director, and I have formal meetings every Wednesday morning at 8:30.
Okay.
We also have meetings with our teams on Thursday and to not only check progress, but also to determine what decisions need to be made so that we can move forward. We have worked together essentially to develop an implementation plan, and we are moving through that plan. It, as you might know, the devil is in the details. And so we are really working to make sure that we have a smooth transition. And so the only way to do it is by having our teams work together. We have, for example, had 4 advances, we don't call them retreats, of our key staff who are working on the transition so that we can share information, generate ideas together, and figure out what the next steps are in the process. And it's been, it's really been a great partnership.
As part of your implementation plan, does that also contain a communications plan as well?
Yes, communication plan. There's a committee that is a part of our framework to do communication both with providers, also with people in care, and also with our other partners. Another thing that Melissa and I do is we also meet together jointly with our providers. During the pandemic, it was every week. Now it's once a month. Great. To keep them updated on what's happening so that they know what's going on with the transition and can give us feedback on our pathway forward.
Okay. So once the transition happens, what will be the rules of engagement in terms of oversight and accountability?
The Department of Behavioral Health as the content expert in behavioral health, will maintain its state authority and will embrace its state authority. So we will establish the standards of care, and the managed care organizations will follow those standards.
All right.
And we will continue to, of course, certify providers with the requirement that all providers, in order to even apply for certification, must have national accreditation.
Okay. Is this agreement with DC Healthcare Finance in writing somewhere? Is the agreement or the rules of engagement, is that written somewhere?
We have an MOU with
Okay.
DHCF, yes.
Is that possible that you can share that with the committee?
Sure.
Okay, great.
Mhm.
Just like to
Sure.
have the receipts, so if
Yes.
something goes wrong, we
We have
don't
an
have folks
MOU.
who are pointing to one another. Okay, so we've heard from providers that they are concerned about, well, change is difficult for anyone, so they are concerned about the transition. But one of the things that they bring up in particular is the possibility of delayed payments for services. And especially for some of the smaller providers, they're concerned what this might mean for their operations and the financial stability of their businesses. Are we thinking about that in particular, and are we looking to provide any additional support there to make sure that these companies can stay financially whole?
Yeah, well, let me talk a little bit about that. Late payment is a little different than what I think they're thinking about. Right now, our providers literally are paid on a weekly basis. As they move to managed care, the managed care companies are required to make payment within a 30-day window. And so there's that delta that they are worried about. And that's something that certainly can be thought through, but I think that is the reason for concern.
Thank you for that clarification, because that is a difference. It is a transition, right? Going from a weekly versus a monthly.
And I think a part of that's one of the reason why we are providing a lot of the technical assistance on some of the business management aspects of working within a managed care organization, because it will be different than simply working with DBH and having claims either flow through DBH to the managed care companies as opposed to directly to the managed care companies. However, I will tell you that we do have many of our providers who are already paneled with at least one of the managed care organizations. And so that's something that we are providing technical assistance and support to, particularly for some of those smaller organizations.
Okay.
Because it is a change.
Yes. Okay.
You have to manage your business differently. You get a paycheck once a week versus if you're getting a paycheck once a month, so.
Right. I'm over my time. Councilmember Lewis George.
Thank you, Chairwoman. Okay. Dr. Basron, I want to start with school-based mental health. In the budget last year, we included a subtitle requiring DBH to, quote, submit to the mayor and council by December 31st, 2022, a cost and program analysis of DBH's school-based behavioral health expansion program. And your oversight responses indicated, however, that your contractor was still receiving surveys from schools and contractors as of January 31st. Can you explain why there's a delay with this assessment and when you all believe a final product will be produced?
We do plan to, and we've been told by the contractor that we will have a draft in February and a final product early in March. And I think some of the delay is related to the contracting process. And we're working through it right now, and we have asked them to move as quickly as possible.
Okay. So the hope was this assessment was to get an updated set of cost estimates in time for the mayor to issue her fiscal year 24 budget. So realistically, I guess that would be, will we be able to, or is there any portions that we would be able to make sure like that we can get so that the mayor can make that consideration when her budget is released?
Yeah, as I said earlier, we are hoping in February, to see sometime this month a draft.
Okay, all right. So I appreciate that. I think if whatever you can do to push the contractor here, so because the hope was that the assessment would get the set of cost estimates in time for the mayor to issue her fiscal year 24 budget. I'm wondering, is there a way for you all to, I guess, without the assessment, to consider, I guess, ensuring there's at least a 10% or 20% increase in base level funding for all community-based organizations who provide behavioral health services in our schools to ensure they can adjust for operational inflation and COLAs for staff retention needs?
We're certainly willing to look at that, but we don't have any data upon which I can make that decision at this point.
Yeah, all right.
So it's hard to
Understand
make a
that.
decision without information.
Okay. And your testimony noted BBH implemented salary increases and hiring and retention bonuses for clinicians. Can you put dollar amounts or percentages to those raises and incentives?
I'm sorry.
I said, in your testimony noted that you all implemented salary increases and hiring and retention and retention bonuses for clinicians. So I was saying, can you put dollar amounts or percentages to those raises and incentives?
Yes, I can. In terms of the money that we have provided to the school-based clinicians.
Yes.
Yes. In term, we for example, we have an $1,000 additional amount per clinician for workforce development to support licensure and any application fees and so forth. We also provided some funding, $16,666 to fund supervisors, that 1-to-6 ratio of supervisors, $53,667 for the core budget for clinician salaries. And then we also had some one-time funding per clinician of $28,000 for this past year. And we used the money that was available because we hadn't filled all of the school-based positions.
Okay, so that's like 16K and 5K per supervisor per clinician.
Yeah, 16.7, you could say.
Okay.
1.6, right. Mm-hmm.
Okay. And can you walk me through the community and school-based mental health expert engagement that happened in designing the questions for the study or survey?
You said, how do we get the questions for the survey?
Yeah, pretty much.
Yes, essentially, we work with, we have the school-based council that is an intimate part of the school-based behavioral health program. And our consultant, evaluation consultant, actually worked with them to identify the questions. We had many meetings where the field, people who are actually providing the services, identified some of the issues and concerns they had that needed to be addressed as a part of this process. It had to do with everything from funding, which was one piece, and the other piece is looking at the model and the services and what could be provided by whom was another issue that was addressed. And so the school-based council, our providers work very closely with our consultant. And as a matter of fact, they also provided the financial information as well as the technical information for that.
Okay, great. Well, I can't wait to get the report and the answers, but it sounds like it will be fruitful and have some really detailed information there. Want to go to some Ward 4 schools for a second. What is the status of counseling services at Roosevelt High School? And am I correct in understanding that they should have both DBH and CBO support, but are currently without a CBO partner? And if so, why is that? And when can we expect for a new partnership to start up? This is only concerning really for me relative to the recent violent incidents in Ward 4 in recent months.
Yeah, I do have a list of the services and supports by school, and I can get that information to you so that you can see what the services are.
Okay. Yeah, based on what I'm seeing in that chart, it looks like I'm want to clarify, because right now it looks like Roosevelt should have both, but don't have both, and are currently without a CPO. So I'm confirming that is correct, and then trying to figure out why, or when we can expect a new partnership to start.
Okay, can you say it again? I'm sorry, I'm having a little difficulty.
I'm sorry. So Roosevelt High School, I was saying, am I correct in understanding that they should have both DBH and CBO support, but are currently without a CBO partner? And if that's what I'm reading, what I'm interpreting from the information I have. And so if so, why is that? And when can we expect a new partnership to start up?
Oh, okay. All right. One of the things that I can share with you is that we released a new RFA to secure additional CBOs to provide the school-based behavioral health clinicians for the schools. This is a part of our process for securing CBOs that we can place in schools. And I really want to make sure that I share with you how a clinician really gets to the school. We put out the RFA. We identify a community-based organization who will be responsible for recruiting and placing the clinician.
Mhm.
Once they have identified clinicians, they then work with the school principal, and the school principal determines whether or not a clinician is appropriate for his school environment. So it is that kind of teaming approach. So we just don't hire somebody and then put them in there. The school has a lot of say about that. And sometimes, we have to go through several iterations to get somebody that school wants.
So, but they do have to have, so the RFA goes to the CBO. So
That's correct.
If Roosevelt doesn't have is it true that Roosevelt doesn't have a CBO support right now? Like a CBO partner? Because that means that we're sort of further behind in the process.
If they don't have a CBO partner at this moment, then they would be a part of the most recent RFA. But as I said, I'll follow up on that because I have a list of all of the schools and what their status is. And so I don't want to tell you something that's not accurate.
Okay. And then another Ward 4 school is Paul Public Charter School, middle and high school. They're both missing a DBH clinician right now. And I believe this position has been vacant since last school year.
Mm-hmm.
Can you elaborate on this position and when we can expect DBH to hire for these schools?
And here again, I think the process that I described is the process that we follow. Many things happen that in terms of vacancies, people leave and move on to other positions. And what we do is work with the CBOs to secure additional clinicians. And then the principal has to agree that that's the person that they want. That's sort of the way it works.
Yeah. So, I mean, what can I do? Because I'm both Roosevelt, Paul also has, one's office has the One's Academy, within it, it is a school where we support a number of students. Both areas have had some incidents of trauma around gun violence and other things. And so I'm just concerned that they are that they're missing a clinician right now and for a full year of school, especially with the state of teen suicide and just what our students are saying they're feeling in school. So what is it that needs to happen to get these schools with the proper staffing?
I wish I had a magic answer for that, because we have over 80 schools without a CBO, and we're working very hard by providing funding for retention bonuses, recruitment bonuses, free supervision, ability to pay for your licensure as a means of attracting clinicians to the school-based behavioral health program. But I must tell you that it's been a difficult task. And so we're working as hard as we can and as fast as we can to do that.
Okay. I have 4 elementary schools: Whittier, Truesdale, Shepherd, and Lafayette. Elementary schools are also without CBO counselors right now. And that's represented also in your report. And so I guess they're under the same book. To remedy these gaps, we would have to, we are sort of under the, the hiring is how we would remedy this gap. And that's what we're working on is what I'm understanding you're saying.
Right. And what our strategy has been is to see to what degree we can work with the existing staff within the school, because there are some mental health staff in the school who are supported by the school, as well as seeing if we can have our non-licensed clinicians or not, who are also in the school provide at least prevention services. If they are connected to a CBO, the CBOs are to provide some support, and particularly for those kids who need treatment services. Treatment services are not to be stopped and are to be continued.
Okay.
And then prevention and intervention services, we would like for them to provide those supports, either the supervisor or someone else from that community-based organization as a stopgap.
Okay. And I hear you. I know you have a long list of schools, and I'm just going through the Ward 4 ones. I'm sure every council member is going to say the same thing. I'm going to say, can you make Roosevelt a priority, Paul a priority, Whittier, Truesdale, Shepherd, and so I know everybody's going to do that, but I have to do it and just say, ask for my schools for it to be a priority to get them the services they need, because their staff are making up for it. I have assistant principals and principals who are acting in these roles in addition to being the principals and assistant principals. They're sort of a part of the support team. So I just want to see if I can support them by getting them the actual clinicians in the schools that they need.
Well, we will accept any support you have in thinking through other recruitment strategies, but we're doing some things in the pipeline, like, for example, working with 3 of our universities around internship programs, looking at Catholic University, Howard University, and what's the other one? And University of Maryland. So that may be another way of getting that service within the schools. We also have an open portal where we kind of jointly advertise for positions across the system, so that we can attract them to school-based behavioral health care. And I have to tell you, the free supervision has been a big thing, because it's very costly if you're an LG and you're trying to sit for your licensure, and you have to pay for each hour of supervision to get free supervision. And so that has been a big thing.
Thank you. I know my time is up. Thank you, Chairwoman.
Thank you, Councilmember Lewis George. We have been joined, those folks who are watching online can't see, we've been joined here in the room by Councilmember Parker as well as Councilmember Pinto from Ward 2. We are on 15-minute rounds. It is Councilmember Parker's turn, and then we'll get to you, Councilmember Pinto. Great. Thank you.
It's great to see you again, Dr. Bazaran. I want to pick up where Councilmember Lewis George left off, and I would just say, as she did, I want us to prioritize Ward 5 schools too, and making sure we feel closure.
I understand.
Just so that's on the record.
I understand.
I want to check my math. So according to my stats, since 2020, 81% of CBOs and about 40% of DBH clinicians have left their schools. Does that ring true? And,
I don't know.
And currently we have
You
90.
mean in terms of lack of retention?
Yes.
Uh-huh.
And currently we have 95 vacancies. Does that resonate?
That sounds right. Yep.
Yep. Can you just speak to why the turnover?
What I have been told by the CBOs, remember they are employees of the CBOs. And what we have been told is that it is because of salary and people get other opportunities.
So primarily it's salary, and I'm sure this sector, like all others, is also impacted by the pandemic. Another very technical question.
Yeah.
When I look at the CBO DBH master list that's online,
Sure.
there are some schools like Brooklyn Middle School, but also Hart, Kelly Miller, Minor, others that were once listed as having a vacant DBH designation, and then it switched to NH or N-A, so not applicable. Can you speak to why that designation changed, and should I interpret that as there's no partnership with that school anymore?
Yeah. I want to kind of go back to your first question,
Okay.
and then I'm going to have Ms. Paulson address the last question. The other thing too is that in addition to salary, I think that we also have to recognize that we're in a new world here since the pandemic. And a lot of clinicians, particularly licensed clinicians, are now able to do very well by working online and never leaving their homes. And that's, a lot of people want to do that as opposed to getting up, coming to school and being within the school environment. And we're seeing that across the board. I mean, you're seeing that in the workforce. In general.
I asked just in the spirit of working with you to find solutions. If we can understand why people are leaving, perhaps we can help fill some of those vacancies.
Those are two big ones, right?
Awesome.
There.
Thank you for that. For that technical question around why are they not listed as vacant anymore?
Thank you for the question. Why they're not listed is, you're correct, that DBH is no longer providing services there. I think a couple of things to note is that there was a reduction in the number of DBH positions out of the DBH budget, as well as DBH looked at prioritizing schools where there was not a CBO partnership. So in terms of schools maybe where we were doubled up, and there was at a time where there was a CBO and a DBH clinician, whether that need was still there and whether we needed to had a school that did not have as you know, we have many that have need, did we need to change that partnership and move that clinician? We have had a number of DBH resignations. And so as folks have left, the decision about, when we recruit then for the next position, where they're going to go. And that is always a conversation that we have with the school and the partnership there. As Dr. Bazaran mentioned, we do a school-centric tool to determine what the needs are of the school. We're always working with our partners around this, what's the best staffing configuration with DCPS and the charters.
So if I'm hearing you, my interpretation of that is there's a shortage. And so we want as many schools to have some presence in the school. And where there may have been a double up between a CBO and DBH, you will withdrew those.
In some cases, I mean, we do
clinicians.
obviously have schools that have extremely high enrollments and extremely high needs. So we're looking at a lot of factors when we make that type of a decision. But we definitely, you're absolutely correct. We're trying to stretch the resources that we have as much as we can, as we're trying to ramp up recruitment. One thing I'll also add to what Dr. Bazran said is that the clinicians are leaving sometimes over salary, but we're also competing with a remote option for many jobs right now. As you may know, some of our folks have gone to the federal government where they've been able to work from home, or they've done telehealth from their home in private practice. So we're competing. We know that school-based behavioral health needs to be in person, and it's not really an option for us to do virtual. So that we have a lot of competition right now for a very limited pool of people.
And one more follow-up there. The ultimate goal is to reestablish those partnerships. Or is that not part of the plan?
The ultimate goal is to have every school staffed with behavioral health resources to the needs that they have.
Right.
And if that means 2, if 3, if it means 1, but that's one of the things that we're looking at in our conversation is about, we've been coming at it from an equality, one size fits all, everybody gets one, but we need to be looking at it from an equity lens as well, because we know that there are some schools that need much more than that. And there may be schools that may need a little less than that because they have other resources.
I appreciate you naming that. And so I just cited Kelly Miller, Brooklyn Middle School, which has been the scene of a big citywide tragedy recently, Hart. Just off the top of my head, these seem like schools that need perhaps a little bit more attention versus this one size fits all. So thank you for that. One other question on this type of mathematical front. In terms of licensed social workers, in May 2020, there were about 4,912 according to the Social Work Board. And in January of this year, there's 5,998 licensed social workers. Does that resonate or seem accurate? And I'm not asking you to cite that, but I guess what I'm getting at here is we're talking about how difficult it is to recruit, retain folk, yet we're seeing a steady increase in licensed social workers according to these numbers. You've already talked about why turnover is happening. Can you just square that, where we're seeing more people licensed and we have a high rate of vacancies?
Well, we're seeing more people licensed and we're seeing them having more options also. I think that based on just looking at the pandemic and looking at the need, for example, for more services in terms of trauma supports than we may have had pre-pandemic. And so that's one of the issues. Also, remember, we're right here at the seat of the federal government. That's another factor. And then also we have a number of private practices within the city.
So as we're thinking legislatively, it's not just about increasing the number of licensed social workers. There's some other considerations because again, we're seeing the number go up.
Right.
And we're not closing the gap perhaps. I'm going to switch.
And the schools are seeing the same thing, not other than school-based behavioral health, but for other school-based positions, seeing the same thing.
I'm going to switch gears. Let's go here. School-based behavioral health services. How are you promoting these to families as well as to students to take advantage of them? One of the things that we heard loud and clear in last week's hearing is that a large portion, I forget the specific number, but I want to say it was over 50% of students didn't know who their behavioral health clinician was. They weren't aware of the services provided. Families weren't aware. So can you speak to how you're advertising?
Sure. First of all, on our school-based council, we also have a very active parent group as a part of that. And so that's one way people might get information. The other way they get it is they get it through their school principal. They get it through their school-based team. They get it through the clinicians that are on site. Our clinicians, for example, meet young people at the door when their parents are dropping them off to have that kind of interaction. And you were in schools just like I was, and you know, that's a real important time.
Mhm.
And that's one of the ways. Also, we attend PTA meetings, which is another place where parents show up. We have a website that has a list of all of the services and supports, including school-based behavioral health care services and where they're located and so forth. And so information is available. However, yeah, and we're trying to push that information out so that people get it. What I've heard from the clinicians is that they provide a lot of information, like early in the morning, at recess, at lunchtime, around those services.
Wha-
And kids walk into their office.
Absolutely. And I don't doubt that you all are sharing information. But
Yeah.
there were upwards of 24 students that testified that say,
Right.
I don't know who my clinician is.
Mhm.
And so a suggestion could be, and this came from one of the students, printing out posters with the services available and
Mhm.
perhaps who the clinician on site is. And if that's something
Sure.
that you're willing to do, I would love to collaborate with you all
Mhm.
to see how we can partner with schools to get more information out.
And I know during, particularly during the pandemic, we held a number of virtual sessions for schools. And so any young person could come into the virtual environment and they were there with their school-based behavioral health clinician to get information, support, to do, virtual support groups and so forth. And that was very successful.
But based on
Yeah.
what we're already talking about in terms of the vacancies, and I would imagine the constant shifting
Sure.
of placements,
Absolutely.
people may not know about the services provided because there isn't someone in their school, given the vacancy. Okay, one other question here, and then I do want to switch to something in your pre-hearing testimony, and it's about, again, sharing information with families. One of the things that we constantly hear from parents generally is that it's hard to find information. My School DC report card is effort to kind of centralize a lot of information. To what extent, or are you open to providing resources, services available to students on site via that report card or My School DC?
Via,
My School DC is a one-stop shop, or at least it's supposed to. Oh, yes. And so, to what extent are you all considering adding information there in
already
terms
do
of
that.
services provided?
Yeah, thank you for that. Yes, we have actually been in conversations with OSSI about that, about us participating in that and making sure that all schools are participating in My School
Right.
DC so that there's accurate information. I also just want to add too that every school is required to have a school-based behavioral health coordinator as part of our school-based expansion, which is a school hired position, but they serve as the hub for the school mental health team. So it's important, and I'm saying this for folks, it was disturbing to hear about the young people that didn't know
That's
who the
right.
clinician was. That kind of like broke my heart because we don't want that, and family members as well. But the school-based health coordinator in every school should know who the name of their clinician is and how to refer directly to the mental health team. If there's no other number or no other person to call, you call the school office and ask for that person, you should have an answer.
That's
We
helpful.
also work really hard with training clinicians to be embedded into the school climate so that they're there when the kids walk in the building in the morning.
Right.
They're there in the hallways. They're doing classroom presentations for universal prevention programs. They're in the lunchroom. They're in after school, so that it also destigmatizes behavioral health in schools. So, and we're really working on that. I think we've always pushed that on the DBH side of the house, and we've really worked hard with our CBO partners through trainings with the supervisors of those clinicians to really push visibility in those schools so that everybody knows who they are.
Thank you for that. And I'm glad to hear that you're in talks with OSSI about
Right.
sharing more of that information. Hopefully we can get that on an upcoming report card. In my last minute, Dr. Bazaran, I want to switch gears to numbers that jumped off the page to me. on page 43 of your pre-hearing responses in terms of the youth prevention service, substance use prevention services in wards 5 and 6 were astronomically high compared to the rest of the city in terms of, I'm trying to read this quickly, substance use prevention services offered to children, 3,257 compared to wards 1 and 2, which were only 775. That was for fiscal year 22. And then again in fiscal year 23, in wards 5 and 6 are 513 compared to wards 1 and 2 at 60. Can you just speak to what is beneath those numbers and why we're seeing such high rates in wards 5 and 6? Or the need for you to provide services at a heightened level in wards 5 and 6?
Well, I think, first of all, we have two A-STEP providers, which are our youth substance use prevention providers, and they do offer services to young people. We actively recruit those young people to services through our prevention centers, and there's a prevention center in 5 and 6. I'm sure you saw that. And then we also make known that those services are available. And if we find a young person who is in, for example, in one of the schools who needs substance use prevention services, then we do it. Why there's that difference in 5 and 6 versus others, I don't know that I can respond to that.
Okay. As a quick follow-up, and I'm over time. After this, if we could, is it possible to provide a more detailed explanation behind the numbers? That would be helpful.
But I'll follow up.
Thank you.
That.
Thank you.
All right, Councilmember Parker. I'm going to take a chair privilege, though, and ask a really quick follow-up, Ms. Paulson, to something that Councilmember Parker said. You noted that every school that is part of the school-based mental health program has to have a coordinator?
Yes, the school-based coordinator.
Okay, is there a list of the coordinators somewhere?
Yes.
We provided that, I think, in our responses. It should be an attachment.
Okay, great. All right, thank you. Councilmember Pinto.
Thank you so much, Chairwoman Henderson. Nice to see you, Dr. Basran, and your team. I want to give a special shout out and gratitude to Phyllis Jones on your team, who has just been so incredibly responsive and really above and beyond helpful to a number of situations. So thank you. I want to focus today on the partnerships that you have with some agencies. As you know, more than most, mental health intersects with almost everything that we do, and get a better sense of how we can improve some of those partnerships. But first, who is the best council liaison? We have constituents calling our office all the time who either need mental health supports themselves or who need it for family, loved one, or someone that they've seen on the street. And is there a council liaison that our offices and all council offices can be going to?
Well, we actually, constituent resources and our community engagement activities really do fall under Ms. Jones. And so that is a good first stop. However, also I would think that Mr. Hall. Yes, Davida Crockett. Yeah. Mm-hmm.
And Davida Crockett. Okay, great. We will go with that. Mm-hmm. Thank you very much. So DMHHS, what is DBH's involvement, if any, with encampment residents? We have a number of encampment residents, some of whom have mental health challenges. McPherson Square is a clear example. We have 74 residents living there. Pathways workers have been out consistently for the last 4 months or so, but there are only 2 Pathways workers who've been assigned there. And one of the consistent feedbacks that we hear from them is we need some more support with mental health. Has DBH visited that site or other encampment sites?
Yes, as a matter of fact, we are very actively involved in the work around the encampments. Our community response team is actively involved and circles through and focuses and talks to people to try to engage them to see if they will go into services. And Dr. Bebout is actually responsible for that activity. We actually work with the homeless outreach teams in partnership with them on a routine basis. And we meet and are part of the encampment activities. And we, provide that support as needed when those things occur.
And when you say circles through, is there a routinized nature of those visits?
Yes.
Can you share what that is?
Yes, good. I'm going to have Dr. Bebout talk specifically about where they go because they do routinely go throughout the city to provide services and supports. And as he talks, though, please understand that at this point, there are a total of 43 staff on the CRT team. We still are working, are staffing up, and we are spreading those resources as we can throughout the city.
Thank you, Dr. Bazran. Thank you for the question. So I don't know Tuesdays at 2 or that kind of thing, but there, McPherson Square specifically is one of our hotspots where we're doing regular outreach on the CRT. I would also add to what Dr. Bazran said that the intensive care coordination team that we stood up this past year under Dr. Moise's direction is also working several times a week to do intensive care coordination conference calls with ICH, with DHS and its contracted partners. We will certainly be there on the 15th and have been intimately involved in many of the encampment responses.
So is it accurate from your perspective that you have been coordinating with Pathways?
It is accurate from my perspective. I think it is important to make a distinction between Pathways and their contracts through DHS for homeless outreach and supports, as opposed to often most people know that Pathways is also a DBH provider, but the Pathways homeless outreach workers are, I think, what you're talking about. And certainly I will reach out to them and be sure that they know how to reach us and that we are partnering effectively with them.
If I may, sorry. Hi. As Dr. Bebout said, our intensive care coordination team's under me. And I can say again, categorically, that we have been working since actually, last spring, prior to the big push to clear out the encampments, working very, very closely with DHS, supporting them to identify folks in the encampments who have behavioral health needs, and then to work with them and develop a relationship and rapport and trust to help them succeed once they get housing. Since then, we have been working also through DHS in the PEPV sites to again do the same thing, to help people be ready for not only address their mental health needs while they're there, but to help them take advantage of opportunities and resources and to be successful. I will say them. So we really work with our agency partners more so than Pathways. We know Pathways, they're a provider of ours, but we don't really work as directly with them. So I think what we may need to do is some better communication and coordination between us and Pathways, because they may not see that we're there, and they may not, these Pathways workers are talking about, may not know what we're actually doing, but we're very, very engaged with our agency partners.
Got it. Okay. I think that would be helpful. So everybody is sharing information in real time and sharing that information with other stakeholders in a coordinated fashion. So gun violence that I believe is really tied to mental health challenges that we're having in our city. I had a very powerful conversation earlier this morning with somebody who, trying to phrase this in a way that doesn't divulge too much public information, but a lot of interaction with young people who were sharing with this person involvement in crime that they were a part of because of very dire circumstances. And in addition to the behavioral health and mental health supports in our schools that you've been talking with a number of our colleagues about, have you all been looking to expand any violence interruption programming in our school communities as we head into this year?
We provide the support for individuals that are impacted by violence. And we do a number of things to support those efforts. However, we are not the violence interrupters. That is not the role that we play. That is not our role. So, for example, in addition to the services that we provide in schools through the anger management and violence prevention kinds of programs, we also have several other specific things that address some of those issues. The Juvenile Behavioral Diversion Program, for example, I think you're aware of that. And that's the program that was started many years ago, actually remember that, during my first term here. And it is done in concert with the DC Superior Court's Juvenile Division, where rather than being prosecuted and a youth can go into behavioral health treatment, and hopefully that helps them become functional within the community and develop some different skills.
And so is that treatment, is that run through DYRS?
No, it's run through the Department of Behavioral Health.
Okay, and how does somebody qualify for that treatment?
There is a very elaborate, there is a criteria in terms of who can be referred. Typically, there are some instances in which youth with extremely violent crime are not referred. I think the Office of the Attorney General has the last say in terms of who gets into that particular program. But it does. We have a team that actually screens those applicants, and the applicants then are approved, and they are in the program, and they receive a range of behavioral health care services. We use the Connor screening tool to identify what their needs are and then provide them with the supports they need. The goal is to stop recidivism and to have them be functional within their community and families.
Mm-hmm.
And so that's one thing. The other thing that we do is that if someone has been impacted by violence, we are there to provide that kind of trauma support. And we do that often and for all kinds of traumatic events. For some of the recent shootings, for example, we've been deployed for instances in which somebody has died within an organization. We're deployed, and our CRT team, along with, depending upon the age, our CHAMPS team address those needs directly and provide ongoing support for individuals who are victims of violence. We also work to provide mental health first aid to as many people as possible so that they can actually have the skills to de-escalate a violent situation so that it doesn't get to that point.
And where's that program run out of?
It's run out of DBH, out of our training institute.
And how does someone get into that program?
We advertise it on our website through our training institute,
Mm-hmm.
and we run classes for that program as a part of that offering.
Okay.
And I think also we need to think about our youngest citizens, like the young people in Healthy Futures, because you got to start early, you got to get upstream. And so we do work with the young kids and their families around pro-social behaviors, around behavior management, so that they don't get to the point where they're acting out and they're violent, because you got to stop it as soon as possible. And then I can't say enough about our DC prevention centers that really focus on pro-social behaviors among adolescents. And we have a youth leadership team in every one of the prevention centers. And I'm very proud of those young people. I went to one of their, I guess you call it conclave, where they were all kind of together and they were learning about not only violence prevention, but also about the opioid epidemic and coming up with ideas around how they should be approaching their colleagues of the same age to get them to change their behaviors.
Thank you for that. And Doctor, I'll ask you two questions in one, so we can be mindful of time. So first, can you elaborate on your partnership with FEMS to both do ride-alongs? That it's my understanding those are going to be expanded for folks who need mental health supports, but also for the sobering centers and how we're going to be helping to get people into those services who may be apprehensive. And then second, can you talk about the ACT program and what the kind of protocol is when somebody is not accepting services or says, I might not need services, but they may be acting in a way that could lead to harm for themselves or others?
Okay. First, I'm really very proud of the way we're developing the Stabilization and Sobering Center. FEMS has been a partner from the very beginning. And actually, we were asked to join in planning the Sobering Center by FEMS. And so our partnership is not only with FEMS, it includes MPD, it includes DC Health, as well as our Medicaid agency. And one of the things that Dr. Holman from FEMS has been very engaged in is helping us to develop the clinical process that will be utilized within the center, our admissions criteria, and really digging down into, what our clinical operations might look like, developing protocols that will be used, because people will not only be able to be brought to the center by FEMS, but also by the police or just to walk in. And we do have a contractor on site. And so that's been very helpful and very useful.
And Doctor, I'm just going to cut you off there because I want to be mindful of time. I will follow up with your team about the ACT program. Thank you very much. Thank you all. Thanks, Chairwoman.
Thank you, Councilmember Pinto. Sorry, we're out here making it work. I noticed we got like 3 laptops going. All of these different pieces here. Thank you for being here, Councilmember Pinto. And her line of questioning, I want to pick up on a couple of things that she was talking about. So first, on the juvenile behavioral diversion program that you all are doing in concert with Superior Court. My understanding is that plus the high fidelity wraparound program are voluntary for young people.
That's right. They're both voluntary.
Okay. So do you all have any statistics or data in terms of the number of individuals where you take them through the criteria and then the families say, no, thank you?
No, I don't know of any denials for service. I don't know what that data looks like.
Okay. I've been having a similar conversation with the OAG's office in general in terms of when they do the diversion programs. I think a lot of people have a notion of what DYRS used to be back in the before times, before the court cases and all of those things. And I know that now they have a full suite of services that they make available from, therapy and those kinds of things that for a young person who is being engaged in the system, you may not need to be committed to DYRS, but you may very much have value for you to avail yourself to some of the therapy programs, et cetera, especially when it comes to anger management and those kinds of things. And so one of the things that I've been trying to think about is how do we increase participation, whether it be sometimes now it's not voluntary. Now as part of your probation, you'll be going to therapy twice a week or whatever it is.
Well, JDP, as you know, there's a choice. You can either go to jail or go to treatment.
Right.
For that program. But we have choice within our system. And so we can't force somebody to get treatment, regardless of whether we think that that's the path they should follow or not. The only instance in which there can be quote unquote forced treatment is if somebody's a danger to self and others and they're FD12 and they wind up in a hospital to support that effort.
Okay. Speaking of that, let's talk about inpatient psychiatric facilities. Well, actually, wait, let me go back really quick to the sobering center. How many beds will that have? I don't even know if we call it beds. Is it seats?
16, I think there's 16 beds that are going to be there.
Okay. And what is the maximum amount of time that someone would be able to?
Well, 20, I'm going to tell you the maximum, I'm going to tell you what the national average is.
Okay.
And so 23 hours
Okay.
is a max, but what we're finding is that if you look at the data for the centers that are existing, people are there, around 6 to 7 hours nationally.
Could I just add a few more
Sure.
thoughts, clarifications? It's really a short stay program. We
Very
bring
short
people
stay.
in,
Mhm.
and we could co-brand this as a FEMS DDH effort, because really, they've been there every step of the
Mhm.
way for the last year,
Right.
helping us to find this. And we anticipate that most of the referrals and people brought in will be brought in by FEMS. And
Mhm.
there'll be walk-ins and referrals from providers as well, but FEMS definitely, probably 80–90%. We've gone and visited other
Right.
similar centers in other
Mhm.
jurisdictions, and that's been their history as well. So the goal is to bring people in, stabilize them, do some crisis management support, certainly medically clear them because they're all going to be somewhat very intoxicated, and want to make sure they're medically clear, and to offer them choices about the next step.
Treatment
So
options.
Treatment options, and refer them, and both psychiatrically if necessary and from an SUD perspective. But the goal is to have everybody there as short a period of time to achieve those goals as possible. And usually it's going to be less than a day.
Okay.
So we're
Right.
viewing it as a
Right.
23.
No, I definitely see it as a
population.
temporary piece. I would say I met with the hospital association last week, this week. My days are running together. Nonetheless, recently, they are excited about this
Yeah.
because they say that there are a lot of people who end up in their emergency
That's
room
exactly right.
who should be at a sobering
Right.
center and
Right.
therefore are taking up a bed when they don't actually
Right.
need
Right.
To do that.
emergency acute care.
I was
Yeah, but-
just, I'm sorry.
Excuse me, the other thing too, I think is really important is that when they come, not only will they be given information and about services, but then the peers they'll follow along service because it's a part of a change process. And so you have to do that engagement until people are ready to get into care. And so I think that's also a very important piece of this.
Now,
Okay.
one to clarify and make sure we're all
Yep.
on the same page. So although that's our standard model, we will have 4 beds. So the
Long-term.
16 are like nice, comfortable recliners, because we don't want people to get too comfortable, because we don't expect them, most of them to stay overnight.
That's why I was like, is it a bed?
No.
Do
it's
we refer to it
really
as
nice
slots?
Recliners that can almost
Right.
go vertical, almost, if you will. But then we're going to have 4, I think it's 4 beds. For
Yeah.
people that with psychiatrically involved issues who we're still assessing and who may
Mm.
not be medically stable, that we can't discharge within the 23 hours. So we'll have a few beds available, real beds,
Okay.
available for people who may need a 2 or up to a 3-day stay to figure out what's the next step and where to refer them to.
Okay. Okay. So let's talk a little bit about inpatient. Inpatient psychiatric facilities. Is DBH on track to expand the capacity at St. Elizabeth's to 250 beds by June?
My understanding is yes, we have a plan to do that.
Okay.
Mhm.
Is that enough to actually meet the need?
Well, our ultimate goal is to get back up to pre-pandemic levels.
What was that?
We ran about 270.
Okay.
But it's a process because we still have COVID, quite frankly. I think many of us think that it's gone away, but it's still there.
Right.
And so we still have to have the ability to cohort individuals, make sure that they are not infected before we put them into the general population. And so that also requires some space. And so within our current facility, I think getting back up to the 270s will be about what we can do.
Okay. Advocates and community members have raised some concerns about some incidents of abuse and neglect at St. Elizabeth's. Your responses included information in terms of how you all have strengthened the safety protocol following one of the tragic incidents that occurred last March. Were there concerns before this happened, that incident in March?
Concerns regarding
Safety in terms of protocols that at St. Elizabeth's?
We've worked, well, first of all, let me say that we work very closely with our PAMI, our protection advocacy organization of the mentally ill. They go frequently to identify any issues they find, be it safety issues or other issues.
Mhm.
And as those issues are raised, and we address them. One of the things that I can say we are doing as a result of some of the data that we've gotten from them is we have enlisted the support of Joan Galeese from the National Association of State Mental Health Program Directors to provide more trauma-informed care. And we provide that training not only to the staff, but also to the patients. And that also is designed to reduce the safety situation. But after that event, we took, as you saw, a number of very significant steps to address that issue and to make the environment much more comfortable. Everything from counting the silverware that people get, making sure that the bed checks are done by 2 people and they're inside the room, and and so forth. And so I think that those sorts of things have even enhanced our process. Oh, and also we look at the film that is shot on the wards.
Got it. Okay. Let's talk a little bit about CPEP, Comprehensive Psychiatric Emergency Program. Look, they gave me a cheat sheet of acronyms that is like 3 pages long, and I still am adding things to it. And these are just DBH. I have a whole other list of acronyms for DC Health, for healthcare finance, for all of the things. I was really shocked to learn that in the entire district, there are only 16 CPEP beds. That does not nearly seems adequate for a city of our size.
Well, we would really like to, and Dr. Bebout is responsible for looking at how we create additional CPEPs in other parts of the city. I think you know that CPEP was created, about 15 years ago? We had our first one when Director Barron was here, and I was the deputy at that point, senior deputy. And we would like to create additional CPEPs in the city. And so that thinking is already underway.
Okay. What's the criteria for that?
In terms of?
External provider, that contract, is that's what I'm trying.
Yeah, I would like to see an external provider.
Okay.
And to run that.
Okay.
Just like the sobering center. I mean, to have somebody contracted to do that.
Okay. Okay. Well, let's check in on that. I'd love to sort of monitor the progress in terms of that work, because 16, given what we're seeing across the city, just seems very limited in terms of the options of where folks have to refer someone to thereafter. Let's talk a little bit about the Psychiatric Institute of Washington. I'm sure you heard a little bit of the, yep.
Thank you. We are eager to expand options for CPEP beds, but when you look at the utilization and the daily census numbers and so forth, we're not at capacity. We are not having to go on diversion. Now, we would like greater geographic diversity.
Right.
We would like the whole system to allow for much increasingly, we're tracking on a daily basis the length of time that law enforcement officers are on site so that it can be easy drop and go
Right.
for them. So there are a number of reasons why we want to strengthen the CPAP capacity citywide and have had significant conversations with potential hospital partners because it is our desire to locate any expansion CPAPs near medical facilities. That's a best practice.
For easy transition.
And certainly this is part of the future planning around hospitals. There is a pretty significant lift in terms of the certification, but many of our hospitals not only do not want to take involuntary patients, they're very reluctant to serve the general population that we serve. So it's not an easy, but we welcome your partnership in terms of thinking about how we might stimulate that. We're well aware that this is a recommendation that came out of the Mayor's Commission on Healthcare Transformation.
Okay, great. I mean, I think everything that you said is valid in terms of all of the pieces. Even too, when we think about like hospitals that take involuntary, with the closure of Providence, we're down a hospital. And so I'm wondering in terms of capacity from that standpoint, but you all can't, I recognize you cannot require a hospital to sign up for these programs.
No.
They have to willingly want to do this work. And it has pieces on them as well. So I understand.
That's right.
Now
Yes.
for the,
However, I do want to make sure that we don't leave with understanding that, if somebody appears at an emergency room and they're in a psychiatric crisis, according to EMTALA, they have to be
absolutely.
cared for.
Absolutely. Yes. Yes. I'm running out of time. I'm trying to keep on my own. There's because there's so much more that we could go from here in terms of, yes, accepting someone in the hospital. Let's say they don't have Medicaid. Let's say they have another insurance where it makes it difficult for us to then, once they have been stabilized, transfer them someplace else.
It depends. For example, within our system, if somebody doesn't have insurance and doesn't have Medicaid and their local only services, then that comes out of our budget. They have a mental health concern.
Out of DBH's budget.
Yes.
I can't get another question off, so I'm going to be mindful. Councilmember Lewis George, are you still with us?
Who is it?
Hi, I'm still here.
Yes, she is. Okay, there you go.
I'm here. I wanted to follow up on the sobering
Lewis George, are
center
you speaking right now?
conversations. It's okay.
We can't hear you.
Yeah. Can you hear me?
No, we can't hear you.
Oh, okay. I was saying, following up on the sobering center conversations, I read your oversight response on the sobering center.
We still can't hear you.
What?
Hold on one second.
I can hear me. I won't. Hello? Hello?
Oh, you want to go after Zach? I hear.
I mean, I was gonna go
Thumbs
now.
up for yes.
No, I was gonna go now.
Oh, she wants to go now. Sorry, I'm lip reading because we can't hear you.
Ready.
No, you might have to go out and come back in.
Okay, I'll do that. Go ahead.
Okay. All right. So we're going to Councilmember Parker, or do you want me to wait? Okay, go ahead. All right, great. Go ahead, Councilmember Parker.
Okay. I'm going to give you a heads up that I'm likely going to bounce around with the question
gonna-
topics.
The first question is around the rate reimbursement to CBOs. And we heard from several providers that the rate hasn't been increased since, I believe it was 2016.
That's right.
I heard in your testimony that we're awaiting the mayor's budget.
Mhm.
And is it fair to characterize that you've made a recommendation for there to be a rate increase to the mayor?
Well, no, the issue is that we want to know how much does it cost to deliver the service? What are the real costs of delivering the service?
So if I were to follow up on that, is it, well, let me ask, do you think it's reasonable to expect that costs to provide care have increased since 2016?
Sure, absolutely.
Okay.
And so that's why I said, what are the costs of delivering this service? And then also what I'd like to see is we build in a COLA so that there is an ongoing escalation over time to kind of keep up with the changing environment.
And so is it fair to assume you gave the recommendation that we should increase the rate?
It is fair to assume that I said we need to look at the data
Fair, okay.
and see what it says.
I got you. But we all agree that costs have gone up to provide care since
We all agree,
2016.
yes.
Okay. One of the other things that I heard from some that does operate out of Ward 5 is that some operations aren't included in reimbursable costs. And they cited some of their outreach activities, namely
correct.
with individuals that are suffering from substance abuse. How can we rectify that issue, that there are organizations that are providing outreach, care, support that are not covered?
Well, first of all, thank you for that question because I agree. And there are a couple of things. One, we want to build outreach services in the general array of services that are offered by the Department of Behavioral Health. And then secondly, through the SOAR grant, we are developing outreach teams that can help to provide some of that support, particularly for individuals with substance use disorders. And so I agree. I think that we do need to have funding for outreach, and DBH and DHCF have both talked about that, and we're in agreement.
Okay. I want to come back to that, but I'm going to shift gears to the Medicaid billing transition. And can you just provide more detail around where we are in the process in that transition? I know you spoke to some of this in your pre-hearing answers, but where are we with the process and what are some of the challenges that we should be mindful of in this process?
Well, first of all, we are spending a lot of time really making sure that providers have the knowledge, skills, ability to function within a managed care environment. And that's billing, that's going through their authorization process, that's going through their consumer satisfaction process, their engagement processes, as well as, service delivery. So that's one thing. The other thing that I think is really important that we haven't talked about is looking at their HIE or their technology. And we have worked to develop an internet technology engine. And what that will do is a couple of things. One, it would allow interoperability in terms of some of the data that's needed to support the delivery of services across provider types. And so, for example, one of the things we are requiring from all of our providers is that they have bi-directional connection to CRISP, which is our HIE. That way they're putting in information on the people they serve, as well as getting information on people they serve. Like, did they go to the hospital? Did they see provider X? What kind of medication are they on? That sort of thing. And I think that as we move to whole person care, that's going to be critical. The other thing is that as we really assume our full state authority responsibilities, we have to really be able to look at the data and tell what's working, what's not working, and why, so that we can then make sure that we can support improvement in services, and we can address issues that aren't working. So I think that that's another thing.
So
That's
is
key.
it fair to then say that two areas that the committee can work with you all on in this transition is around both technology for providers, because what I can imagine could happen and we don't want to happen is it's now time to transition, but X number of providers are now having a meltdown because technology is not up to speed and or whatever the case. And the second being on the data collection aspect so that we can do a quality control of
Well,
sorts.
if I can speak to the IT piece, we've worked very closely with our Medicaid agency, and we are providing an array of very specific technical supports for providers around building out their IT platform, as well as we have a consultant that's also working to help them in terms of providing guidance.
Can you
around
share
that.
with us just a status of where those providers are? Like, even if it's like a red, yellow, green, green being like they're ready, red meaning like these people need support. Again, we just don't want to get to the point where it's now time to transition and half of
I'm
the
going to ask
providers.
Mr. Neff to come up, who is
Okay.
in charge of that area. But I can tell you this, our providers are moving along, and we actually have the ability to provide them with milestone payments as they make progress. And so there's some incentives to move along, as well as providing the technical expertise, the how-to in terms of what is required. And I think that that's very important. So it's
Yeah.
not just the mandate, but it's what supports are available.
Could you introduce yourself for the record? Thank you.
Good afternoon. I'm Michael Neff. I'm the Chief Operating Officer at DBH. I'd like to talk briefly about two things that will assist the providers in the system transformation process. And the first is a program called Rev Up. And Rev Up is the continuation of a program that was begun by the Department of Healthcare Financing. And its sole purpose is to work with providers to learn how to manage their revenue cycle process. So when it's specifically targeted to learning how to work with managed care organizations to make sure that that process of getting authorizations, doing billing is consistent with the district's managed care organizations. That will begin, I think we're final review of the RFP to go out to select a vendor. And it'll be available for all behavioral health providers to take part in it so they can prepare to look at operations and how they can manage that. And so from the previous experience with the program run by the Department of Healthcare Financing, we have really strong data to show that it was successful because the pilot specifically worked with DBH's substance use disorder providers, and they really came a long way to be able to demonstrate that they could learn how to do appropriate billing. The second piece is a program that already has 88% of our providers involved, and that is a program managed by the Department of Healthcare Finance. We are working conjointly with them, and it provides the incentive for track 1, 2, or 3. So if a provider needs to purchase a completely new IT system, funding is available for that, and it's an incentive program. So as you go through 6 steps, you get payments to help you get through that process. In the track 2 is to enhance a system that you currently have, and you get a certain amount of money against 6 payments. And then the track 3 is if you need to help build out, specifically if you need to do some work to develop reporting or have certain interfaces to hook into like Chris DC, for example, you get payments to do that.
I'm glad to hear about the incentives and what seems to be robust support for providers. And I guess what's behind my question is that perfect storm that Chair Henderson was talking about before, that we have the health emergency that is sunsetting at the same time that this transitioning is happening. And we all know, even with the best of plans, a lot can go wrong. And so it would be helpful if we could just have some type of status check at a date certain where providers are with the transition. I also note that even though that's a high percentage, 88% is not 100%.
That's correct.
And so what immediately jumped out is, what are we doing for that lagging 12% to get them on track? And so
I can tell you,
Yes.
we do one-on-one support, one-on-one support, and as well as group support, because we really want our providers to be successful.
thank you for that.
And I would also note that we are concerned about our handful of other providers that are not participating. And we reach out to them regularly to find out why. We have a number that are sophisticated. They are currently in the MCO networks. They have their own systems and they're proficient in billing. And not a large number of those providers, but that certainly helps understand some of that gap.
Thank you for that. Two other questions very quickly, also unrelated. One, you referenced the 988 transition. And I just wanted to make sure I understood your testimony. So you were saying there is a 90% response rate for those calling in. What does that mean?
Okay, what that means is the phone rings. And the data is determined by how many of those phone calls are answered.
Got it.
And so 90% of the calls that come in are answered. The national rate is 80%. So we're doing very well.
So my interpretation originally,
Yeah.
that's helpful, was that 90% of folk were being connected to a provider of support. But it seems like it's actually just about answering the phones.
It's
So
an
let
answer
me,
rate.
if I may clarify,
Yeah.
it's the Lifeline, which formerly the National Suicide Prevention Lifeline, now the 988 Suicide and Crisis Line, is a network of 200 centers around the country.
Yes.
The premium is on local answer rate because the local specialists are
At
most
range.
effective at connecting people to the local resources. What we're talking about is if a call is not answered in a specified period of time, it rolls automatically to another sister
Got it.
Mhm.
call
Got it.
center. So the nationwide, the standard that was established for the July 16th go live in 2022 was 80%. We're operating at or above the 90% local
Got it.
answer rate. And
It's helpful.
Right.
That clarification is helpful. So it's not like the call goes
Oh,
unanswered.
no.
It just is rerouted to another
No, because
jurisdiction.
if you don't answer the call, it can either go someplace else or it can drop.
Got it.
And the person gets nothing. And so when the call is answered, then somebody is on the other end to provide them with support they need.
Okay. And I want to ask a follow-up there, but I will pivot to the diversion program, which by all accounts, I think has been successful. And you all deserve credit for that. It is my understanding, though, that FIMS is not included in some of those conversions to when the calls are coming in. And so what some of the feedback that I've heard is that there may be duplicative work or people are being rerouted back around because FIMS wasn't included in the initial rerouting or provided data. I'm seeing faces, so that doesn't.
I'm not
No.
sure. Are you talking about the 911 behavioral health
Yes.
call
Oh, you
diversion
see?
program?
Yes.
No. What happens in the diversion, if I can just explain that particular component, a call comes into 911.
Yes.
Rather than the dispatcher calling the police to go out and address that call. If it appears that it's a mental health related issue, the call comes to us.
And it's
And then
my
we
understanding, based on
dispatch.
feedback, and I'm out of time. So Chair, could I?
And then we
Yeah,
dispatch.
60 seconds. The feedback that I've gotten is after that call is rerouted to you all, a subset of those calls are then rerouted back to FIMS and others. Whereas if they were included in some of the initial conversations, there could be a greater level of accuracy.
So
What?
I'm puzzled by that
I am
because
too.
FEMS is at the table with our twice weekly calls. We have an internal call and we have a weekly meeting with the
Okay.
Harvard Kennedy School Government Performance Lab. We got one of 4 jurisdictions that got a year-long intensive TA. Dr. Holman and his team are faithful participants. But I do think.
And this isn't a shame and blame
No,
moment. It's about.
No, I'm puzzled and would like to learn more and happy to hear directly. The transition from historically at OUC, everybody got law enforcement, ambulance, or fire department. Now there are 7 or 8 different diversions. And so getting that all just right, including the nurse triage line and so forth, is complicated. It is one of the things that we think, one of the ways that the whole program and initiative will benefit once we are able to co-locate staff is that because FEMS has staff at the OUC call center.
Right.
I am way over time, but thank you for that. And I'll follow up on that.
Thank you, Councilmember Parker. Director Bazaran, we've been going for about 2.5 hours. Would you like to take a break for?
Sure.
Okay. Councilmember Lewis George, if you don't mind, we'll take a 5-minute break just to allow
Testing,
stretch our legs,
testing.
et cetera.
Is that working?
If you're
Testing.
talking, we still can't hear you.
That's why I decided to do this. Testing. Testing. Testing 1, 2, 3. No? Okay. I'm just going to keep testing over here.
Yes.
I'm sorry, I can't hear you. I have snacks. Oh, thank you. I'm done today, yeah. Yeah, like technically tomorrow, but I'm kind of turning everything in today. Thank you, I will. Yes. I know it, Thank you. Alexandria, I'm gonna work for the Center for Children and Families. And so it's all things kids and families. It's not just it's child welfare, youth development, like DB special. So yeah, it's broader, yeah. So I'm excited about it. It's gonna be a big challenge. Yeah, I think they're pushing to get people back. I mean, they're actually, their folks have they've been virtual full time. So I think they're gradually bringing people back. I think they'll probably be like 4 days in, 1 out. That's what they're moving towards. Relationships suffer. Yeah, and I'm gonna try to get to know the community more, so I can give my feedback and, but yeah, I'm hoping to do a little bit of virtual. I think it's good, but, just, well, Yes. We'll tell you. Yeah, so, good. Hopefully preference is coming down, but it's still out here. But hopefully, it's really. I never had a lot of
Testing. Did that work, y'all? Yeah.
Okay, we're gonna reconvene. Councilmember Lewis George, I think we worked through the technical issue.
I think the mic is ready.
It is ready. Go ahead.
All right. Second. Okay. Dr. Bazaran, I wanted to follow up on the sobering center conversations. I read your oversight response on the sobering center, and I heard the conversation now. As basically as a program that would be government operated, not a program that would be operated by a third party community partner. Is that correct?
No, that is not correct.
Okay.
We actually have a contracted provider who will be
Okay.
operating that service, and we're glad happy to tell you that our provider, CBI, has actually developed 20 some of these sobering centers in different parts. So they're very, very well versed in how these operate.
Okay, I appreciate that. And I think that actually is a better way, the better way to go, especially with someone with that experience. I also read and heard the Sobering Center discussion as a program that is addiction recovery oriented first and foremost. And, while I applaud that and think we all want to break cycles of addiction, I think one of the most important lessons I heard from my trip to a harm reduction site in New York City is that people gradually come for recovery, but need to be welcomed as users first. And that is why their safe consumption and drug checking program is so important to building trust. So I was interested in how will our center accomplish that? Did you all discuss a safe consumption component of this center?
No, we have not discussed a safe consumption site center within the district. I think that is a discussion that really requires a great policy discussion as you look at what's happened in other states and where I think we only have 2 in the United States now, and that's in New York City.
In New York City, yeah.
The one in Philadelphia, as you know, from a policy perspective, was not approved, and the one on the West Coast also was not approved. So I do know that there was a committee of our Live Long DC group that actually did some research on this and developed a document. And so, that's something, certainly all options are possibilities, but it requires much more discussion.
Okay. Well, I agree, and that's why we went up there I went up there and was able to visit the two sites that are operating in New York City. Going in, I was sort of skeptical and a little worried about what this would look like, but being there and seeing the work that they're doing and how effective it actually is gave me some hope that this is actually something that is worth exploring here in our jurisdiction as well. And the lives that they have been able to save as a result of it was also something I think is something worth exploring. And I hope that that's something we can talk about exploring, or if your team can visit the New York site just to explore and see if this is something we should be considering in DC. The other piece, as you noted, the Sobering Center will only have 16 beds. So it's a relatively limited service, meaning we need to be increasing outreach in other ways. So in addition to safe syringe programs, what mobile outreach and especially mobile drug testing programs has DBH expanded or created to help keep residents safe from fentanyl overdoses?
I think you probably have seen our huge van. We have a very large mobile van that does provide information, education, naloxone, fentanyl strips, and a connection to care. If somebody wants, for example, to be inducted into buprenorphine, then those prescriptions and so forth can be written. And it circulates throughout our city. And so that is one thing that we do. The other thing is that we have a number of outreach teams that are out there working on the ground every single day. It's more than just a CRT team. We also have teams that are funded through our state opioid response grant, who are also
Okay.
out there working to provide education, naloxone, and so forth. We have 3 syringe provider contractors that are also offering safe syringes, naloxone, fentanyl test strips, and so forth in the environment. So we do have a lot of outreach, and I think that the outreach is important because that's step one. And along with that outreach is the engagement to engage those individuals so that they can really think about moving into recovery and then eventually make that.
Yeah. Okay. And I appreciate that. And so in addition to CRTs, you have, what's the other team called?
We have the state opioid response team has a number
Okay.
of providers and of outreach teams in addition to the syringe services team.
And the syringe services team. Okay. And then with each of these teams, do you all sort of, what kind of data collection do you all do? Do you have anything that sort of allows us to be able to sort of, like,
We have 4 syringe.
like how many people the mobile van is engaging each day, and how many, what wards the mobile van has touched, and sort of just some of the metrics for how many people they're engaging each day and week, and where it's
Yes.
where they're engaging.
Yes, we do have that particular from our contracted providers.
Okay, so there is a tracking mechanism to sort of just
Yes.
test out and making sure that we're being effective in that work.
Right.
Okay, great. And moving to actually CRTs, wanted to dig into, actually, can you explain the meaning of the crisis codes associated with the CRT call? So on page 90 of the oversight responses, what is a crisis assessment, and what sort of situation gets coded that way?
Dr. Bebout? Go ahead. I can do it. Go ahead.
Crisis assessment is just the initial evaluation and screening of what's going on. What are the crisis drivers?
Okay. And then it says co-responses. And what who are the co-responses? Who are they with?
Mm-hmm.
So we often respond in tandem. We do not yet, as Dr. Bazran said in her testimony, however, we are looking at the development of a formal co-response model that pairs behavioral health specialists with law enforcement officers. But MPD and CRT often both are responding to certain situations, and that's what we're referring to as a co-response.
Okay. And what sort of situation gets coded as mental health?
If it's primary mental health rather than a substance use related crisis or acute intoxication.
Okay, got it. Okay. And so, and do we have total numbers? But basically, do we have location based metrics for the CRT engagements?
Mm-hmm.
We do, and I think we shared in our written responses ward level data about CRT responses.
Correct.
Okay, I'll take a look in that. Last year, I know we funded 36 more FTEs for the CRT program, but you note that we still have 22 vacancies and 5 candidates in the pipeline, with 65 CRTs currently employed. Can you tell me more about CRT staffing expansions over the past year? Like, what are the staffing levels per shift by ward or geographic assignment, for example?
So we're actually geographically we're divided in 2. There's one location that serves primarily 6, 7, and 8, and another location that serves 1, 2, 3, 4, and 5. We are looking at a number of options. Dr. Bazran directed me last week to be looking at possible locations for satellite sites. We are also looking at the staffing pattern, the shift structure, to make sure that we are maximizing the spread of available staff over and matching it to peak period.
Okay. And what are the education credentials or professional backgrounds of CRT employees?
They are peers.
Okay.
So they could be a certified peer. They could
Okay.
be a licensed clinician, or
Okay.
they could be a trained mental health clinician.
Okay. Okay. And so what as far as recruitment goes and turnovers goes, what are we seeing as far as turnover and tenure trends with CRT employees, and what are some of the barriers to recruitment at the moment?
So, as was discussed earlier, obviously there are hiring challenges. These are incredibly difficult jobs, and we heard some about that in last week's testimony. One of the things that we are working to do, Dr. Bazran earlier mentioned Dr. Joan Galise from the National Association of State Mental Health Program Directors and her team, which specializes in trauma-informed care. We've engaged her and her team to work with us to develop best practices around promoting resilience and supporting our staff in terms of ongoing self-care, as well as the kinds of critical incidents that really warrant routine sort of debriefing and review. Because these are incredibly difficult positions. CRT is working incredibly hard to expand. It is, for all the reasons that were cited earlier, it's not easy to get people that are wanting to work in the field, meaning literally out in the community and in the street.
Yeah.
And it's 24/7, which so the evening and overnight and weekend positions are also more difficult to fill.
Okay. So are CRT employees part-time?
No, they're full-time employees.
They're full-time positions. Okay. And what is the pay range for CRT employees?
I can get it for you.
Okay. I'm just trying to, what I'm trying to do is get to how we can get more in the sense. And then residents still report all the time that they call for CRT or maybe an alternative to police responses, and are told that no one is available, and so police alone get sent out. So I think there's a disconnect in sort of what's I guess what you're saying in the community is feeling. And so I'd love to work with you all going forward this year to make sure the community really understands this program and how to use it, because that has also one of the things that has come up. I want to have room for one more question. I want to go to Healthy Futures for a second. With the Healthy Futures program at Oversight last year, you had noted that hiring for Healthy Futures early childhood behavioral programs have been slightly easier than hiring for the school-based mental health programs. But I also see a number of staffing challenges reflected in your oversight response, including being short 16 Healthy Futures consultants and lacking staff for the family counseling pilot that was funded last year. What's going on here, and what are the barriers to hiring you're uniquely facing for your young child programming, and what sort of retention challenges are we seeing there?
Yeah, I hate to be a recorded message. I really do. But we are here again on the treatment side. We want licensed clinicians. And so that's the same situation that we're running into in the other areas where we're trying to find licensed clinicians to do this particular work. However, I think that we are at the point where 16 of our 26 positions are filled. We do have 3 supervisors and a program manager on site right now. And we are really working to fill the remaining positions. And we're working very hard to do that. And we're hoping that people want to work with our youngest residents and they find that attractive.
Okay.
But, but even with that, I think it's really important to note that one of the reasons this program was started several years ago was because we had a lot of young people who, believe it or not, were being expelled from child development centers. They were being expelled. Over the past couple of years, we've had 0 expulsions because of the work that we've been able to do with the adults as well as the families and the children.
Well, which I think is great. So what is the connectivity of healthy oh, I'm sorry, I didn't see that. My bad.
Thank you. I was just trying to be mindful of time because Councilmember Parker is also still here as well. And so, we're going to do another round and then some if you need a little bit more time. Or did you have like one more question?
I had like one more question. And I'm be done. I'm leaving y'all.
Okay. Okay, go ahead.
So I wanted to, with Healthy Futures and school-based mental health programs, I just wanted to understand the longitudinal connection, basically ensuring that there's sort of no lapse in service or a cliff that occurs between the two. What does that longitudinal connection look like?
Well, the Healthy Futures program, as you know, is designed for child development centers and also for the private homes where services are provided in a congregate setting for these young people. And then they go into a school. And our elementary and early childhood schools are also included as a part of the school-based behavioral health program. And so there is that constant connection, that consistent connection, I should say.
Okay, so there's not like a cliff, like sort of like a cliff.
No, there's no cliff.
Okay, great. Thank you. Thank you, Chairwoman. I appreciate it.
Thank you.
And thank you, Dr. Bazaran. Thank you to the entire team. Thank you all very much.
Thank you.
Thank you, Councilmember Lewis George. Dr. Bazaran, there's so many different ways I could go on where I wanted to go next, but she started talking about Healthy Futures, and so I want to talk a little bit about that, but also let's talk about money, because while I recognize that some people enjoy working from home, there are incentives to leave your confines of your house, and sometimes money could be part of that. And in that, right, obviously we have a finite amount of money that we had available from a local, but we have quite a bit of money available to us in ARPA. And so we did some digging, and so I want to ask some questions about that, Healthy Futures being sort of one of them. So to make sure that we're all starting from the same numbers, is your AFO here, by the way? Maybe just,
Yes,
okay, great,
please,
wonderful. I don't need him now, but he might need him in a minute.
Right back there.
I just want to make sure that, we got somebody
I
here.
brought everybody to the table.
Okay, so my understanding is that DBH for FY22 got about $10.2 million in ARPA funding. Is that about?
That sounds right. to
Okay,
me.
that sounds right to you. Okay, great. Now, of that, what I am seeing from the data dump that we got from the CFO's office and our budget office, that in FY22, you only spent about 4.8 million of that. So let's talk a little bit more programmatic specifics. So for instance, on Healthy Futures, in the spend plan that the mayor submitted, there was a planned expansion, or it was called Healthy Futures Expansion.
Right.
And for FY22, it said that you had about $480,000 that was budgeted for that. The same amount for this year, FY23, and the same amount for FY24. However, only $150,000 was spent.
That's because that was for staff salaries and we couldn't hire staff.
Okay, so you provided it, but you weren't able to hire for.
Correct.
Can I add something?
Sure.
I just want to add something too. It was also for a program evaluation.
Right.
And we have just now gotten the contract with that vendor for evaluation in this fiscal year.
Okay, so the program evaluation will be how many years?
This year and next. 23, 24.
Okay, 23, 24. So you will, I guess it will anticipate a change, an update in your spend plan for when we get the revised budget,
Right.
because you still have 22 money available,
Mhm.
presumably, correct?
We applied for carryover, I think.
Yes, we got it.
Yeah.
Yes.
Okay. All right. Intensive care coordination management. That had a budget of 1.1 million or
Mhm.
1,100,448 for FY 22, 23, and 24. I'm showing that so far, well, for FY 22, only about $200,000 was spent.
And that had to do with recruitment. We are now at the point where we are staffed, and so you should see a change in that.
Okay. So recruitment and care coordination.
Mm-hmm.
Okay.
And here again, it's a similar type of staff.
Okay, just to go back, Ms. Paulson, I'm sorry, are you Dr. Paulson? I want to make sure I'm, okay. I'd like to give people their due in terms of their titles. Ms. Paulson, when do you anticipate the program evaluation to be complete?
So that's going to be an ongoing evaluation, but they just started, they just signed the contract. So our staff just met with them last week. So
Okay.
Right.
Just signed contract, okay. Okay. Expansion of telehealth services was included to set up 10 telehealth stations through DBH and impact approximately 4,150 residents. In FY 22, you had 2.7 million that was budgeted, and I'm showing only 123,000 was spent.
Right, and I can explain that.
Okay.
First of all, there were two issues. One issue was that we had to get some legal determination in terms of whether or not we could actually buy the pieces of equipment to give them out and what we needed to do around that. We got that situated. The other issue was a supply chain issue.
Okay.
Where we literally could not get the pieces of equipment. And we are just at the point now where we're able to get the pieces of equipment and set it up. And we do plan to set those up this year. Dr. Moise is responsible for that, working with our COO. And we have resolved those issues and plan to move forward.
Okay. You know, while you're talking about the equipment piece, I'm thinking of a conversation I had with Children's, where they're also trying to do telehealth to set up in schools, but they're also needing to purchase equipment too. And it feels to me that everybody's buying equipment for the same room, i.e. in the health suite or whatever. Like there should be some collaboration that's going on here. I'm not sure. Well, let me ask this. Have you all picked where you're going to put your stations?
Yes.
Are any of them in schools?
No.
No. Okay.
No, none of them are in schools, and ours are really community-based.
Okay.
Because we really want them out there in the community so that there's easy access for people who may not have equipment, but may be more apt to use telehealth for
Okay.
their treatment than in person.
Okay. Something for us to keep in mind in the future, because if everybody's buying computers for the same
Absolutely.
telehealth services and they're going to be in the same places, we can do that. You had a budget line item for family wellness and support program to continue and strengthen weekly wellness Wednesday workshops and maintain an access line. I'm showing that you budgeted $544,000, but you only spent $6,954.
Okay.
Right. So we also made a pivot as the pandemic was winding down. We wanted to do more public events for family wellness, because while it was really critical during the pandemic when everybody was in their homes to be on a virtual wellness meeting, as kids went back to school, parents went back to work, we saw some of the attendance really go down in terms of virtual sessions. We still offer that on a monthly basis, the virtual, but we wanted to do more neighborhood-based events. We were unable to hire the family coordinator position. So we've been using internal staff. And we also are just now getting the vendor to sign. We have a social marketing contract that is attached to that enhancement, where we really want to get out social messaging, social marketing messaging around wellness, especially as DBH moves into more of a role around health promotion.
Okay, so let me back up. Are all of your positions just posted on DCHR? Like, do you have to go through the DCHR? Like, if I wanted to apply for a job at DBH, do I have to go through the DCHR application process to get to you?
Independent hiring authority.
You have independent hiring authority. Okay. I'm trying to reconcile what is going on within our government, not just DBH, but everyone has these vacancies. Meanwhile, I got constituents who are looking for jobs. And I'm just feeling like somewhere we are not, like your family wellness and support coordinator, I can't imagine that that's somebody who's required to have some sort of specialized licensure.
No, you're right. It does not. But we're still having a hard time recruiting around the salary.
How much is it?
I think it's around $70,000 to $80,000.
It's a reasonable salary.
It's a reasonable salary.
I thought you were going to say something like 40, and I was going to be like, okay, come on, Ms. Paul,
Nope. It's a reasonable salary.
I think it's reasonable. Okay. Are we gonna work on this? Because I'm like, I know people. If for it's one thing if you need a licensed clinician for something. I know what those situations are. But for other people who, because I think this came up actually during the hearing last week, where someone was talking about needing to have more people with lived experience working with some of these programs to help be able to provide feedback on some of these things.
And we've hired a lot of them, as you could tell.
Yeah. Okay.
Yeah.
We're gonna keep working on that. All right. Let me ask some more. Sorry, on the ARPA. DBH Educator Mental Health Program to offer mental health supports to teachers and school staff,
That's right.
which is incredibly important. You all had $293,000 budgeted for this. However, only about $80,000 was spent.
But we're well on our way this year. So that's good news. We actually hired the person, a full-time person for the educator wellness.
Okay.
She's been phenomenal and has really done a number of events. And we continue to do educator wellness. And we're coordinating a lot with DCPS and OSSI and the charter board around what makes sense. I will say we really were flexible around doing virtual sessions with the teachers. And we provided wellness support to educators after the Uvalde tragedy because there was a lot of really emotional reactions to that from teachers, in our district. So we've been creative and we continue to do both in-person and virtual, and we're doing the rollout of the Healthy Teachers Support group that's going to be starting, I believe, this month. So we're very excited about that as well. So it's moving in the right direction, but we did, again, have to get the person on board and, work with some of these outside vendors around getting it set up.
Okay. I'm asking these questions because, well, number one, it's federal money. I don't want to send this money back. I don't see an extension of ARPA happening anywhere in this, what's happening on the other end of Pennsylvania Avenue. And so I don't want us to have to send not a dollar or a cent back, which is why I'm asking some of these questions. One of your other ARPA pieces was to establish a behavioral response for specific types of 911 calls for the community response team. There's budgeted about $5 million in FY 22, 23, and 24. FY 22, less than $1 million was spent. Was this also a hiring situation as well?
Yes, this is the hiring for expansion positions for the community response team and for Access Helpline. One of the things that has changed is that these positions were built into the long-term spend plan.
Right.
And have been reclassified. They're no longer NTE or term positions. They're career positions. So that's a barrier that has been removed.
Okay. Well, that's great. So let's talk about CRT. We're going to come back to budget because I have some capital questions too. I didn't realize y'all had as much capital money as you do. Anywho, but on CRT, we had a witness who testified last week.
Now let me find my question. Sharing sort of harrowing experiences, sort of working in this field, not just for him, but also for some of his colleagues, including assaults, robberies, having guns pulled on them while on duty. We talked about some of the supports you all are providing for educators, which is great. What resources or supports are we providing for your CRT staff, including contractors who are working in pretty stressful environments and they themselves may be triggered by some of those encounters?
I think that I'd like to speak to that. I heard that testimony, and I think that that's one of the reasons why we have brought in a consultant to work on providing trauma support to our internal staff. And I think that that will be extremely useful. Also, when there is a significant issue, all of my executive team members and supervisors are to reach out to those people to see what's going on. I often do it myself.
That's good to hear. And in terms of that, the work of that consultant, has it begun yet? And
it has been, and they have a very well structured and well utilized and proven, for lack of a better term, program manual curriculum that they follow, and it's really made a difference in a number of agencies across the country, not just here within the District of Columbia.
Okay, good. What was most heartbreaking about the testimony from last week is that that same individual testified on the exact same issue prior to the pandemic. Prior to the pandemic.
Oh, okay.
And I know that only because it was in-person testimony. There was a photo online about that. And so it seems as though this has been a persistent issue. And so I'm glad that you're hiring a consultant here.
Absolutely.
But I hope that we can have some more meaningful thought around how do we support these individuals, especially if we want to do the expansion pieces. Think of it as sort of a retention initiative in the same way.
But I think it's, I think supporting your employees, period, is important. And particularly, all of us have gone through the pandemic. And even those of us who may not have had an issue prior to the pandemic, all of us have been impacted in some way. And so throughout the pandemic and now, I feel that it's really important for us to put some resources into providing those supports for our internal staff as well as for the people they serve. And the CRT team, certainly they are out there in the field. They see all kinds of traumatizing events, and they need to be able to have a place to debrief, which is why we have supervisors, and the supervisory sessions are so important for them to have an opportunity to kind of unpack some of that stuff. We've looked at things like, how should we adjust schedules? What do we need to do to provide additional supports for them? How do we make sure that EAP is available to them, as well as the additional supports from places like the one that I'm telling you about, Dr. Golis.
Okay, I'm over my time. Councilmember Parker.
Thank you. A very specific question. So the level set for those that may be watching, the PEP-V program is sunsetting. The PEP-V program is an emergency response to house medically fragile individuals. And that housing was done in Ward 5 and hotels along the New York Avenue corridor. In your testimony, you spoke to the ways in which you're supporting residents in that program. So my first question is, can you just characterize again what type of support you're providing? And then I'm going to give you the second question, which is, given this news that that program is sunsetting, what impact is that having on the services that DBH is able to provide to these medically fragile individuals?
Well, first of all, I think that there are two ways. One, we are actually funding the grant that is being implemented by MBI, who's one of our providers, who's providing the mental health services and supports. And so what we learned as a part of that process and doing the data bump is that a large majority of the individuals that are in those PEP-B sites are also connected to care within the Department of Behavioral Health. So we want to continue the care coordination to make sure they don't fall out of service. And
That's good to hear.
well,
Yeah, and I'm not surprised to hear that. But I guess the concern that many have, and I share, is that with the sunsetting of this program, there is no guarantee that those individuals are going to be put up elsewhere and are not going to end up on the street. And so when we talk about the services you're providing, part of that is because they're in a centralized location to receive those services. And if they are then scattered across the district or surrounding areas, it begs the question how that might impact your support.
Well, here again, we work also in the community with people who are on the street and continue to provide them with service and supports. We know that there is a push to try to find housing for these individuals. Our MBI contract does work with having and helping them to establish a housing plan so that they can step out of the PEP-B site and into a secure housing.
And you all are owning that part of it? The housing? No, that's
DHS.
DHS. That's what I would expect.
And we work very closely with DHS in terms of that.
So is it fair to
We
then,
can't guarantee.
is it fair to then say that you would not expect services to stop for these individuals
No,
even as that program sunsets?
no, I don't.
Okay.
That's not my expectation.
Thank you. I want to switch gears. Before I get to the drug crisis in the district, which is a big focus, and we had opportunity to talk about that.
Yeah.
I want to just end my questions on that. But before, educator wellness, Ms. Polson, you spoke about that coordinator. Is it a coordinator position you just hired?
Yes, it's a coordinator for the
And my
program.
understanding is that that coordinator is working with sub-providers that are being dispatched to schools to work with schools. Is that accurate?
So the providers providing wellness activities as well as support activities, and that coordinator is working with vendors. So she isn't the only person that's providing the supportive activities.
So DBH as an entity isn't providing the wellness support to teachers, but it's more so through contractor providers.
It's a combination. So
Got
the
it.
coordinator actually does facilitate some of the workshops and some of the sessions with the educators. So she's very active in
And I'm
that.
going somewhere with this. So
Okay.
how many schools are currently in that program?
Anybody, any school, any teacher is invited to participate in our program. So
Interesting. I
Yeah.
did not know that.
Yeah.
Because there is a push to scale the teacher wellness program for this coming fiscal year. And I was going to get your read on that because it was shocking to hear some say, we need more money for this program. And you tell Chair Henderson, oh, we just hired the coordinator recently. So can you square those two things? And do you actually agree that more money is needed at this time to scale that program?
Well, I think it's important that our program is based on the NARPA enhancement, which we've talked about as a temporary, it's temporary money. We really believe in supporting the educators. I mean, the enhancement came out, of course, COVID, and coming back into, first it was around virtual learning and supporting teachers in that environment, and then coming back into school and just supporting the return. But we know that there's so many other areas where educators need support. It's a very
Absolutely.
tough job. We ask our teachers to do all kinds of things. And so, DBH, I think, does support, ongoing educator wellness. And we are in conversations with OSSI around how that is going to roll out. And so we're in favor of it. I think we don't want to duplicate efforts of what we're doing right now with what's coming up the pike. So those conversations are really around, what is that going to look like on a school level? We offered the educator wellness program, though, when we wrote the enhancement, we were really thinking about it. We were still virtual at the time. So we were thinking about, lunchtime virtual sessions online that teachers could, at their convenience, And also free consultations to teachers. We also provided that. We still do that, really
So
to anybody.
essentially, a teacher at school X would have to seek out or sign up for this coordinator or one of the providers versus it being a provider dedicated to a school.
Right, it's not right, exactly. It's not like the school-based behavioral health program where we're talking about one person for every school. The free consultations can be accessed by calling our Access Helpline and asking
That
to
is good
speak
to
with
know.
somebody. It's that easy. The virtual sessions.
I don't think a lot of teachers know about that.
Oh, well,
Do you have already that hotline number? Or can you share it after?
Sure.
Oh, yeah,
Okay.
absolutely.
Okay, thank you.
It's.
Do you want us to tell you?
1-888-7
Oh, yeah, if you have it, I'll-
1-888-7, we help.
Okay, say that one more time. I'm sorry.
1-888-7-9, we help.
79, we
Yeah,
help.
well, yeah, and we'll give you the number.
Okay,
We'll give
thank
all
you.
the numbers.
Help. Because I want to help advertise it because I
That's
don't
right.
think a lot of teachers even know that
Yeah.
support exists.
Yes.
Oh, and she's decoded it. 888-793-4357.
Thank you. Thank you.
I use the acronym.
No, I really appreciate that. Okay, now to the drug crisis in the district. And these will be my last questions. One of the statistics that continues to be jarring as the district faces a lot of challenges around public safety are the number of people that are dying because of drug-related deaths. And that number continues to rise. So I appreciate it. Is
Go
that not accurate?
No, we're finding that it's coming down a little.
Okay, okay.
Mhm.
My interpretation was that the rate of the increase slowed, but that we're still seeing more people die of overdose.
Well, 343 between with January and October.
Okay. I appreciated the detail and the specificity in your responses to the work you all are doing in the community. And I just wanted to follow up on one of the things that one of the people that testified last week on was the need to build out an ecosystem. He emphasized the word ecosystem.
Right.
It is not enough to just have syringes. It's not enough just to have,
correct.
even as some people are advocating 24 harm reduction centers, that we need to think about how these things are coexisting to provide an ecosystem of care. To that end, can you speak to the ecosystem that currently exists at a 10,000 foot level? And where are there gaps and low-hanging fruit opportunities for us on this end, the legislative end, to kind of address some of the gaps in the ecosystem?
Okay, within the ecosystem, the things that you said before, which we think are important, but we also have a provider network that really provides services within the ASAM framework. We do find that we do have, we are continuing to build that out. And so that's one piece of it, because you got to have treatment. You also have to have, and I see it as prevention, intervention, treatment, and recovery, and interdiction. I mean, I think that's the framework. I've talked to you earlier about all of our prevention services within our prevention centers and the other activities we're doing in terms of community education and outreach to kind of destigmatize everything. Intervention is one of the things that happen particularly among the younger population. When you see individuals beginning to move in the wrong direction, you help them with good decision-making, like the Too Good for Drugs, evidence-based practice, helping them to think through and have other options for solving their problems so they don't use drugs to anesthetize themselves.
And if you had a magic wand and say, if we could tomorrow implement a new program, a pilot, a system of support, would it be more of what we're already doing? Is there something we're not doing that we should be doing?
Well, I think that one of the things that we're looking at is how do we have recovery housing for youth? And we actually are planning to look at and to move forward in that area. The other thing.
And when you say
that-
recovery housing,
a
recovery,
place where clean living can happen
Gotcha.
for a child or a young person that's been addicted to drugs. The other thing that we want to do is expand the number of providers that are available for young people who are impacted by substance use disorders. And that's another issue. We also, within that ecosystem, do have the ability to have medication-assisted treatment.
Mhm.
We have all 3 approved medicines available within our environment that can be used by people who qualify and at their choice. So everybody doesn't have to go into an MAT center, an opioid center. They can get buprenorphine, they can get naltrexone, there are a number of things. The other thing that within the ecosystem are the recovery supports. That includes housing. You got to have a place to go. You got to have something meaningful to do during the day. And that's why we have supported employment services, as well as the educational opportunities for young people.
Thank
And
you.
then the piece that is outside of our wheelhouse is interdiction. So what's happening in terms of, for example, I think you've seen in the news that young people in some of our surrounding jurisdictions have gotten a hold of fentanyl in pill form.
Yes.
So how's that being interdicted so that we don't have that into our system? Because we have to work together as a community to address this.
And it seems like, thank you for that. I'm just being mindful of my time, and I want to end
does that
on time.
answer the
It does.
question?
It does.
Okay.
Thank you. Really helpful. Two follow up. So I see in your responses on page 64, you talk about that youth treatment facility that it seems like you're bringing one online this year.
Mhm.
Is that accurate? How many beds or young people will you be able to support in that type of facility?
The residents. Huh? The RFP has just gone out.
Okay.
Mhm.
It
Yeah,
hasn't gone
just
out, but
going
if you could just follow up, I would be
Absolutely.
interested,
Mhm.
as
I
well
was
as,
excited.
do you know where that's going to be located?
The RFP has just gone out.
All right, okay. All right, and I'm getting somewhere. And so
Okay.
in Ivy City, there were a number of individuals in short order in time that died of drug overdose.
Mhm.
And it's a crisis issue in that part of Ward 5, Ivy City, Trinidad. In fact, there are other areas. If you drive down North Capitol on a good day, you will see people in crisis. And I want to just hone in on like some of the mobile units that you speak to, and like how can we work together to dispatch those mobile units to those areas, because I never see the mobile units. I'm sure they're out, and I'm sure we don't have enough of them. And so that's kind of a softball question around like how can we work together, the Ward 5 council member and DBH, to get care to those that need it most in those crisis areas.
Yeah, and we have responded certainly to the community's needs around where the mobile units need to circulate, and have actually made arrangements for them to be stationed at different places on a particular day of the week, a particular
Nice.
time. And so if that's
Can we
one of the
follow up and talk
discussions
about
that you'd like to
stations in
follow
Ward
up
5?
with, then I welcome your call.
Is it reasonable to expect that there might be a station in Ward 5? There could be a station in Ward 5?
Well,
I think there is.
there is.
There is.
Yeah, we already do.
Okay, we'll follow up.
Yeah.
But thank you. That is my time.
We already do.
okay.
But, happy to have that discussion.
Yes, thank you.
Thank you, Councilmember Parker. Did you have one more question you wanted to follow? Oh, okay, he wrapped that up. Wonderful. Okay, I don't see any of my other colleagues here. We've had a lot of visitors today. I have to say, like, this actually makes me feel really good that my colleagues came to the hearing and provided rich questions to, I think, inform the conversation. But I think it's also helpful for you all to know what colleagues around the city are thinking about, what they find to be important, and ways we can collaborate to improve the whole ecosystem in terms of behavioral health that we're providing here. I'm gonna like fire through this as fast as I can. And then we'll do some follow-up stuff. But again, we'll see you in like, I don't know, a month or two for the budget. So
For the budget hearing.
we'll talk more then in terms of that. But I do want to follow up in terms of the conversation that you were having with Councilmember Parker around the need for some of these conversations to not just be within jurisdiction, especially since we know we have young people who are going back and forth, right? DC, Maryland, Virginia, that we need to work together on this. I understand that you all have a partnership with Fairfax County Community Services Board in
Right.
Northern Virginia.
On youth, for youth.
On youth, yes.
Right.
Are you having any other conversations with neighboring jurisdictions around young people?
Children's Hospital, certainly, because that's where the expert is located. Other than that, not to my knowledge, not
Okay.
around substance use disorder.
Okay, I think that might be an area where we need to start to
Sure.
like forge some relationships, because if fentanyl pills are in Northern Virginia, they're going to
They're
end
gonna
up in
be
the
here.
district. And so that needs to be, I think it's not even, I would say, the
Yeah.
responsibility of just DBH. MPD should be aware of what they're looking for. FIMS should be aware of what's happening there, all of those things. as
Well, now I can say that as the state commissioner here, I do have regular interactions with the commissioner in both Maryland, Virginia, West Virginia, Delaware, which is a part of our region. We have those regional meetings on an ongoing time period through our SAMHSA regional director. And
Great.
so we do exchange that information, and we exchange best practices, and we try to generate ideas around what's working and what's not working. And so we're not doing it in isolation, but we don't have a formal MOU or anything
Right,
like
right.
that.
And
So we
I
do
don't
have that
necessarily think a
discussion.
formal anything is necessary,
Yeah, well,
but it
that's why I
is good
said,
to
no,
sort
we
of
don't
have conversations.
But we
with
have those
that.
conversations, and one of we all, our team belongs to the National Association of State Mental Health Program Directors, and they have sub groups, as well as the National Association of State Alcohol and Drug Abuse Directors, and they also have it. And I happen to work with all of them and actually be officers on those particular members of those boards. But
Great.
the thing that's important is that we are not working in isolation. We are working in tandem with our partnering states, as well as with our federal partners across the United States.
Great. Okay. Staying on young people and adolescents just for a minute, and we had testimony from Children's that talked about last week around them seeing an uptick in the number of adolescents who are coming in for treatment for substance abuse, even some having to be admitted to the ICU. In a separate conversation, some of our charter schools raised that they haven't yet been provided access to Narcan. And so I want to ask for an update on the plans to make sure that all of the LEAs, go ahead.
I can tell you, we had to, because each LEA is its own school district,
Yes, I know.
we have to have an individual MOU signed by each LEA. I actually met with the LEAs several weeks ago, or probably a couple months ago, to talk about the fact that we wanted to enter into an agreement with them. We have since that time worked through the MOU. It has been signed off by all parties, and now LEAs can sign on the dotted line, and we have the medicine, and we're ready to give it to them.
So how many LEAs so far have signed?
None at this, huh? It went live today.
Oh, it went live today.
Mhm.
All right,
None-
look at this
none at
breaking
this time.
news.
Yeah.
Okay, so I can follow up with these
Sure.
leaders and say,
It's available.
okay, perhaps, because I don't want nefarious activity offline, if you all can provide us with whatever the website information and that we can provide to those charter leaders specifically who inquired,
Sure.
to just let them know, hey, this is
Sure,
available to you.
Sure,
Okay,
but I
great.
did physically go to the charter board meeting and talk to people about it because I think this is so very important.
Okay. And in that vein, are we all good in terms of ensuring that DPR and our library facilities have a supply?
I think, do they have them at the library, Sharon? Yeah, I think they do. I think we do.
Well, I mean, DPR, we'll put that to the side.
Yeah.
DCPL, given the population of individuals there, you know,
Mhm.
and seeing them as community hubs, I want to make
We-
sure that our libraries have access.
Yeah, but I can tell you, any entity that has requested them from us, we've made it available to them.
Okay, so proactive, okay, not a problem. Staying on opioids, but switching to budget, because we gotta talk about the money. The overall budget for state opioid response activity was about 37.7 million. So that's inclusive of all of the funding sources, local, federal, grants, whatever we need. Interestingly, though, the local funding source for this is only around 10%, at least from my
Right.
numbers.
Most of it is SOAR money.
Right.
And the state opioid budget for we have some carryover money, by the way. And so we have 6.7 in carryover. And then we have 24,139,141 in FY23. And we expect to get that 24 million in the next couple of out years.
Okay, so how long does this money sort of carry over for? Because I know we had carryover from FY21.
Okay.
Like, at what point does it expire, or are these non-lapsing?
They're not non-lapsing. We have to get approval
Okay,
every time. And my understanding, and Sharon can probably speak to this better, is it, but every year we have to apply for it.
oh, she's gotta come to the mic. I can hear her, but
Right.
the people, if you can introduce yourself
So,
then.
hi, I'm Sharon
Alexa.
Hunt. I'm the
Uh-huh.
State Opioid Treatment Authority.
Huh.
And each grant, we had a SOAR 1, a SOAR 2, and a SOAR 3 grant. SOAR 1, that money would expire after, we can do a carryover in year 1. Year
Expires
2,
in-
then we can do a no-cost extension. So it will only go through a 3rd year as a no-cost extension. Then we started on SOAR 2, and now
Right.
we are currently in a no-cost extension for SOAR 2. And we have started year 1 of SOAR 3. So.
Okay,
Does
okay,
make
that makes sense.
Mhm.
Yes. You know, I don't like to give the federal government their money back. We're
No,
gonna
we're
spend
trying
that
to spend
money.
every dollar.
Oh, great. I'm glad we are in alignment on that. All right, I'm trying to be mindful of the time. Let's talk about capital. Who manages your capital projects? Is that done in-house, or do you all use DGS and you are a client of DGS?
We are a
for-
client of DGS, and we do manage some in-house, and our chief operating officer does that.
Okay. I don't know if he wants to come back to the table. I have some questions. And so with that, you all have independent procurement authority?
I'm sorry,
Do
no,
you
we
have-
do not have independent.
Okay, so when you're doing capital projects, it still goes through OCP?
Yeah.
Okay, all right. When you have work orders, is that an in-house system? Or do you submit work orders for, let me back up, for properties that you all have and you have issues with those properties? If there's an issue, did your work order go through DGS, or do
Yes.
you all have a contractor for whom you manage maintenance issues with?
Maintenance.
It's hybrid. It's
Right.
not just one process. So for our sites, CPAP 35 K Street, 821 Howard Road, we go through DGS.
Okay,
The hospital has its own maintenance department.
great.
And I think I've only seen 3 or 4 requests go through DGS for those.
Okay, so my next question was going to be, how's your relationship with DGS? Because they are on my list for some other situations. So I just want to make sure y'all are good. Are there any outstanding requests from DGS that you would like a nudge from the council on?
No,
No, I mean, we
okay.
work very closely.
we work very closely and very well with them.
Director Anderson has 2 emails in his inbox. If he is listening, I'd like a response to my letters. Okay, so now I want to talk about the budget pieces, and I understand, pre-encumbered, encumbered, those different pieces. Okay, so facility upgrades line, excuse me. And it looks like to me, so in FY 2021 and 22, the council funded nearly 7.3 million in allotments for facility upgrades under DBH, but only 1.3 million has been expended during this time, and you have a balance of about 6.8 million at this particular juncture. In addition to that, you have about 9.5 million that is budgeted this year and 9.5 million that is shown for FY 24. I know that can change, but in total, it's looking like DBH will have about 16.3 million over the next 2 years for facility upgrades. What is the plan for spending that money?
I don't manage that. So there's a piece of it that was delayed due to the pandemic, which are site upgrades for Octo and DCNet. And those need to be completed for CPAP, St. Elizabeth's Hospital, and 35 K Street. It has been completed for 821 Howard Road. The next site that'll be worked on is 35 K Street.
Can I ask for, okay, so 821 Howard Road, because I have a note here that says you were going to do the wireless upgrade,
Right.
VoIP, staffing area enhancements. And so you're saying that that project is complete. Okay, great. All right. Okay, so the wireless upgrades are still needed for K Street and
CPAP and St. Elizabeth's.
okay, and do you have an updated timeline on those?
So,
Yep, you gotta come to the table, sorry.
yeah, so COVID ravaged operations, right? In the following regard, contractors were not allowed. So we had to put in place a number of restrictions where we limited who could come on the property, and supply chain issues, et cetera. So there was a real pause created by COVID for the period you mentioned, 21, 22.
Mhm.
And so now we have ramped back up operations. The prevalence is declining. Many of the projects, floor program at the hospital, security surveillance system project, dietary upgrades are all ramping back up and moving swiftly forward.
Okay,
in
so
progress. So-
while you're here, let me ask then about that. There's a project titled HVAC modernization for St. Elizabeth's,
Moving forward,
1.3 million.
yes.
What is the definition of moving forward? Like, is there a contractor?
Contractor selected.
Okay,
Contractors are now being allowed to come on site, do the planning, and prepare to implement on all those projects.
okay.
The floor program replacement.
Oh, I didn't even have the
Completed 2
floor.
unit-
I was gonna ask about the replace the thermal docking station,
Yes, dietary.
the tray line, yeah, all the stuff in the main kitchen.
Contractor selected, yes.
Contractor selected, okay?
We meet every week on these projects.
Okay, and thermal, the intercom system replacement?
Yes, the planning is moving forward on that,
Okay,
yes.
planning moving forward.
So contractors are coming on site, doing the planning and evaluation of the facilities, doing the technical evaluations. So
Okay.
all of the projects at the hospital, the lion's share of the money you just described is committed and is moving forward.
Okay, and the pharmacy medicine dispensing upgrade?
Yes.
Yes.
Pyxis.
That's a Pyxis.
Pyxis.
Done.
Oh, it's
Yeah.
finished.
Yeah.
Okay, great. Wonderful. All right, so let me, I might regret asking this out loud, but I'm gonna do it anyway before we get there for the budget. Nope, you know what? I'm not. I'm gonna keep my mouth shut. We're gonna handle that one offline because I don't wanna telegraph anything to Jenny Reed in the budget office on that. Right. Okay. Thank you. On those. It is important for us to have justification on these projects because whether it's us, whether it's other committees, whether it's the chairman, and they're looking for money and they're going to do a sweep and they're looking at some of these project lines where money has been sitting for a period of time. I need to have the justification to be able to defend why it should not move and why it is necessary.
Right, and I think a lot of it, during COVID, we just weren't able to do a lot of things because of supply chain, because of patient safety, for a lot of those reasons. And so now we're open.
Yep.
And we're doing it.
No, it's good to hear though that these projects are getting done because I mean, I would tell you, like, I've been to senior wellness centers who are also waiting for wireless upgrades. And for them, it's like, yes, COVID, but also we are moving our programming on, or we have tried to move our programming online to engage more seniors, but our wireless doesn't work in the building.
Right.
So like, you can't continue to do program on some of these critical infrastructure pieces. So we want to make sure that that is happening. I have to ask about the Psychiatric Institute of Washington. You and I talked about this, privately when we met. Well, to go back to that altogether. So my understanding is that Psychiatric Institute of Washington, United Medical Center, and Washington Hospital Center are the only facilities that contract for inpatient psychiatric services.
That's correct.
That is correct. Okay. Was there one other hospital? Was this something that Providence used to do?
Providence was a big provider, a very large provider, and we lost a lot of beds when they closed.
Okay. Oh, sorry. Okay. How many facilities does DBH contract with outside of the district to provide inpatient psychiatric services?
We don't contract with any outside of the district.
So only in the district?
Yes.
Okay.
And it's the 3 providers that you mentioned, 3 hospitals.
Have we ever reached a stage where we have hit max capacity at all of these facilities?
Well, it depends because, as you know, hospitals do have the ability to flex beds. And we have, X number of bed days that we contract with them for. And then if we exceed that, then we do negotiate with them to see what can be done. So that's kind of where we are, but we have not contracted in Maryland or Virginia for beds for DC residents.
Okay. You said in your pre-hearing responses that DBH has established discharge policy that includes the procedures for an effective and safe discharge. Yet we still hear from advocates and other elected officials in the district that patients are being discharged without medication or actual plan for follow-up services.
Yes.
And I understand in particular when it comes to PIW, there is a delicate balance here because DBH and DC government does not run that facility. We contract with the facility for certain beds. And putting that to the side though, I think a lot of people turn to DBH. Are you okay? Okay. I want to make sure that you got some water. Okay, great. I want to make, there are a lot of people who turn to DBH because you also license facilities. And so you have oversight over those oversight over facilities in general, or is it DC Health?
Okay. First of all, DC Health is the licensing agency for all of the hospitals within the District of Columbia.
Is PIW considered?
PIW, yes.
It's considered a
Yes,
hospital.
It is a hospital.
Okay.
Absolutely. And so one of the things that happens is that we certainly work in tandem with DC Health when issues occur. And if there are issues related to the patients that are under our jurisdiction, Then we follow up, we do our investigations, we can put them on a corrective action plan and then hold them accountable for that plan. Recently, we actually did that. And our integrated care unit was really responsible for meeting with them on a routine basis and going through the checklist of issues, including discharge planning, and when discharge actually began, making sure, and they would go in and do unannounced chart reviews to see what was happening in terms of patient care. In addition, DC Health does their on-sites. We do them independently and we can do them together. Most recently, Dr. Lewis and I met with Dr. Mark Fleming, who is the acting CEO of PIW, to really talk through some of these issues and say, what is the plan? This is gotta do something differently. And so we have begun that kind of working relationship here, as well as in terms of doing the checks of charts.
Okay. So hearing this, I'm gonna ask similar questions to DC Health, because I hear you when you're saying you're doing the checking the charts, you're doing the
That's right.
conversations, you're doing all of these pieces. And yet I'm still hearing from residents in Ward 3 that, especially those that are right in that immediate area, there's still issues where folks are being discharged without even proper clothing, which I think you and I both feel is unacceptable in terms of a safe and appropriate discharge of an individual. So let's continue to work on that. I want to ask about, I'm trying to get through this as fast as I can in some ways, and then we can follow up on some of these other things. For CRT, when they are deployed to a call and there are children who are present, what happens?
Mm-hmm. Well, I think that and I'm glad you said that, because one of the things that I've directed our staff to do in terms of the CRT, Dr. Bebout, is actually to add people with child experience on the team. And so that is something that will happen. However, when children are involved, our therapists are really trained to work with the whole family. We know that, children exist within families, and having done that work myself, if there are kids involved, then you certainly provide for the needs of the entire family and refer them appropriately to the appropriate services once the crisis has been resolved. So.
Okay. That came up a little bit last week, and just sort of making sure that we have the appropriate number, or the appropriate people at the scene to help triage a particular
Dr. Bebout is
issue.
working very hard to get that kind of.
Well, so let's talk about staffing really quickly, and I'm going to wrap up here, because again, I want to be mindful of everyone's time and all of that. Staffing is the thing that we have talked about the most. It's the thing that I feel like everybody brings up: the hospitals, the providers, the whole nine. And I've also bring this up with DC Health. So we're going to do a hearing on February 28th and bring in some of the licensing boards. I say bring in. I don't mean it to be in sort of that way, but sort of a, hey, we haven't talked to you in a minute. What are y'all doing? Because we're also hearing some of the licensing challenges that are happening. How are we progressing in terms of regional compacts so that individuals who are licensed in Maryland can also provide services here, those kinds of things. I'm wondering, to what extent are you communicating or collaborating with the various licensing boards that impact your agency? Board of Psychology, Board of Pharmacy, Board of Social Work. I think Councilmember Parker brought up earlier, we're seeing an increase in numbers in the licensure, and I'm putting it in air quotes because I know that just in the same way that we might be seeing an increase in the number of lawyers in the district, there are lots of people who are going through the bar process, but they are not actively practicing law.
Right.
They are working here and other things. And so
are you all having conversations around the work that they're doing, particularly when they're having particularly when the boards are discussing licensure requirements?
I think that, first of all, I'd like to make sure that we all acknowledge the work that the mayor has directed all of the agency directors to do together across the city. I think you know that we are putting together a workforce, a development, recruitment, and retention plan for across the city. And Dr. Lewis actually is chairing that particular process, and all of us have had input into that. Now, specifically around the boards, my conversations have been directly with Dr. Lewis, because as you know, the boards really fit within that framework in terms of how we move forward. I think that when the report is actually issued, you'll see that there are a lot of different ideas that really have been recommended by a wide variety of stakeholders. I mean, your hospitals there, you have nursing home owners there, you have government officials there, you have public, it's a very wide array of individuals that has ideas around what the plan can be for us to move from where we are now to where we need to be so that we can secure the people that we need. So.
Okay, that's good to hear. I know that the DC Health is working now. They've just finalized one compact agreement with Maryland. Are you itching for your folks to be the next one? I don't know the order of operations, who goes when,
Well, I think that the compacts, as I understand it, are really for different types of clinically trained people. So you could have a compact, and the compact could involve social workers. It could be one for physicians. It could be one, and it's around licensing and how that license is accepted and what the reciprocity is and so forth. And so, Dr. Lewis and I have been really talking through some of those issues, and I look forward to continuing that work.
Okay. That's all my questions for right now, because I feel like we've been doing this since 2 and 4 hours. We've covered a lot of ground today. And so I appreciate you and your team for being here. I have a list. Do you have a list? I want to say it out loud of what we said the follow-ups would be so that we can reconcile the list. Yes, the MOU with healthcare finance on the transition, as well as a copy of the transition plans. Councilmember Lewis George asked for the list of services and supports by school. I think you guys said you had that already, but if you could just send that along.
I think that was a part of the response.
Oh, so we might already have it. We'll double check.
Part of the response.
The third thing I have is a detailed explanation on why substance use prevention services were high in wards 5 and 6 compared with the other wards. I believe that came from Councilmember Parker. Councilmember Lewis George asked about, or maybe not her, it could have been Pinto, but somebody asked about the rate of pay and salary for the critical response team.
Mm-hmm.
We asked for information on the SUD community-based treatment facility for youth. I think you said you were preparing to release the RFP, and I think Councilmember Parker asked for some information on that. And then the link or information that we can provide to charter LEAs to sign up for receiving Narcan.
Okay, so we have the MOU, it's complete. And all they need to do is kind of sign the MOU, and we can provide them with the training as well as the naloxone.
Yep. Okay. Yep. You just turn your mic on.
One additional thing was the progress of the providers
Oh, yes, red, green, yellow, or,
Yeah, and it doesn't have to be red, green, yellow, but some type of progress report around which providers are on track to meet the
On provider
transition.
readiness.
Yes. Thank you.
okay. Dr. Bazaran, this concludes my questioning and this concludes this hearing. I have some things I have to say here and then we can wrap up. I want to thank you again for providing testimony and information to the committee. If we have additional questions, we'll reach out. But I think we can anticipate that our next formal hearing will be for the budget process. And I think you all have that date, time, and information. If anyone who would like to submit testimony who wasn't able to testify last week, as a reminder, the public record for the Department of Behavioral Health will remain open until 5 p.m. next Wednesday, February 15th. You may email your statement to astrange@dccouncil.gov or leave a voicemail at 202-430-6046. If you choose to use that option, please speak slowly and be sure to give us your first and last name. A lot of people forget to provide their name. Our next performance oversight hearing for the Committee on Health will be for the Deputy Mayor for Health and Human Services and the Department of Healthcare Finance on Thursday, February 16th. The time is 6:04 p.m. and this hearing is adjourned. Thank you. And thank you to cable television and to the Office of the Secretary for their support of this hearing. Thank you.
Thank you.
That's it.
Yeah.